Well, good morning and welcome to all of those who are here today for this special informational hearing of the Budget Subcommittee 3 of the Senate, Health and Human Services. I do want to acknowledge that this hearing today is also being live streamed over the internet, so we welcome any members of the listening or viewing audience who are joining us remotely via computer hookup. That's linked on my Senate website. If anyone is trying to find it, who is hearing but not seeing, you can just Google Senator Bill Monning and it'll take you to that site. I want to thank all of you who are here, particularly those who have agreed to be part of our panel. The background for this in working particularly as chair of the Budget Committee on Health and Human Services. We've struggled with very tough budgets over the last several years, and always the balancing act of how do you balance a limited and stretched state budget while protecting public health, public safety. I think one of the key issues that people expect from their government is public safety and protection of the public health. So we're going to hear examples today of some of the health trends in our state, in our nation, and also trends in disease and illness, and many of those preventable disease and illness, and trying to understand what is an appropriate role of government in regulating the sale of certain products or the manufacture of certain materials where there is a proven consequent health risk, either in the environment or in things that people consume. We'll hear examples of some of the successes over the years, both federally and statewide, of controlling tobacco consumption, and what are some of the tools that government has to protect public health or try to prevent cost shifting, where the cost impact of a particular public health risk is shifted to the government and to the taxpayers. So that's kind of the incentive. I think I'm not going to say a whole lot more at this point. I think one of our aspirations is to hear both some of the, preliminarily, some of the economic analysis of what this means when we talk about externalities or negative external impacts in our government, how costs can be shifted in terms of a private sector selling a product or manufacturing a product, and then government and taxpayers shouldering the cost of those adverse or negative impacts. We'll then move to some public health experts who will share some testimony on both successful public health interventions, where we can see what was the problem, what was the public or governmental intervention, and how has that resulted in better health outcomes or reducing, from an economic point of view, that drag on government and taxpayers. We'll also look at some current issues of interest that may lend themselves to various types of greater concern, oversight, potential appropriate intervention, again with the goal of protecting the public health. And I just want to say at the outset, very often in government and very often on the Budget Committee, we're always looking at bottom lines measured in dollars and cents. And when we talk about public health, it's critical to understand that in addition to the cost, the economic cost to our society, to taxpayers, we're also talking about a cost to the quality of life. We're talking about reduced lifespans. We're talking about complicated medical management of people for whatever reasons have been exposed to toxins or ingested food or developed habits that have had an adverse impact on their health, then the quality of life, then tying up family resources, resulting in lost days of work. And so we have different ways of measuring the cost of some of these public health impacts, only one of which is economic. And so I do want to keep in the forefront, and we'll ask some of our witnesses in the public health sector to measure not just dollars and cents, but quality of life issues, how they tie up an economy, how they lose our economy, money in terms of workforce, et cetera. So with that oversight, I know that we'll be joined by Senator DeSaulnier today, who is a former chair of this committee and with whom I have talked extensively about these issues. I also want to thank Michelle Bass, our chief consultant on the committee, for her groundwork and preparation, and for all of you who have shared part of your day to come as witnesses or as interested members of the public or various stakeholder groups. So with that overview, I'd like to invite Dr. Richard Scheffler to come forward, Professor of Public Health and Public Policy, UC Berkeley, and also Linda Rudolph, who will be testifying about public policy as a tool for improving the public's health. And welcome to you both, and I think by prior arrangement, we'll lead off with Dr. Scheffler's testimony, followed by Dr. Rudolph, and then we'll open it up to our questions. And I would remind those here in the live audience, following our planned panels today, we will have an opportunity for public comment. So would ask you to consider any observations or comments you might want to make when we get to that point in our agenda. And with that overview, I want to thank you both. Dr. Scheffler, welcome. Dr. Rudolph, welcome. And we'll lead off Dr. Scheffler with your overview and comments. Thank you.
Thank you, Senator. Good morning, everyone. My background is in health economics and public policy, and I'm on the faculty at UC Berkeley in the School of Public Health and the Goldman School of Public Policy. So this session is essentially what I do at Berkeley and have been doing for the last 30 plus years. So I'm pleased to make some comments and provide some overview, and I hope we can dig into some of this with your questions and concerns afterwards. So, Senator, I think that you understand that the U.S. As a country and California as a state is based on the notion that the market is the way we will deliver and produce services in the United States. There is no such thing as really a free market. A free market would be a market where there was no government, there was no interference in the marketplace, and essentially it's a conceptual kind of nirvana, and we use it as a way of teaching, but it really doesn't exist. But the philosophy of markets is very important. It's believed that by using markets, we produce things in the most efficient way. And efficiency is the thing that is best done through market principles. And what we mean by a market is there are buyers and sellers. So the market is set up to produce efficiency. It is not set up to be equitable or fair. So number one, the market is for efficiency. Efficiency usually meaning producing things the best way, measured using barometers like lowest cost, or even lowest cost and highest quality. But it's not set up to be fair, it's not set up to be equitable, it's not set up to protect the public health. It's set up to do things efficiently. So under the best circumstances, that's what markets do. And in the United States and in California, we have a strong feeling that markets make sense because we have a strong culture of individual freedom. And individual freedom in markets means choice. We can choose things. And the individual choice would also allow us to choose things perhaps that aren't so good for ourselves, like eating too much or smoking or drinking, the usual behaviors. And we have to balance individual freedom with the protection of the good for the common and the public health. So for many, many years, there was, of course, an understanding and science that smoking wasn't good for you. But yet, using that as an example, before we would regulate smoking, in the sense of saying you can't smoke in this restaurant, you can't smoke in a particular area, there had to be scientific evidence that showed smoking not only was bad for you, but it was bad for people around you. And until the science could prove what we end up calling secondhand smoking, there was no role in many people's minds for the government. If you decided you would smoke and decided it was worth whatever smoking was to you and the health consequences, that was a private decision for a private person to make in the marketplace. When your smoking affected my health, or perhaps even your children's health, then in fact there was a role for government. That is the classic term of what your write-up, which is very well done, I might say, I had a chance to read it this morning, calls externalities. That's essentially a negative externality. So it not only affects me, but it affects others as well. The classic case in public health is used when we say that you must vaccinate your children. In the United States, we have a very odd way of forcing you to vaccinate your children. We don't say you have to vaccinate your children for public health. We say you have to send your children to school, and they must be educated. But in order to go to our schools, they must be vaccinated. So in the United States, we have an odd way. We don't, for many things, like to regulate directly public health, particularly when it goes close to what the parent will do with their child. But when your child is going to go into a school, if that child has something, it passes it on to other children. Therefore, we say you must vaccinate your child. So we have to carefully understand the balance of public health and individual freedom. In this particular case, education is the thing which is mandated, because citizens, as you well know, Senator, need to be able to vote. They need to be able to vote. They need to be able to read. They need to understand a stop sign. And so for all of us, education is a high priority, but to be in that classroom, your child has to be vaccinated to protect other children as well. So I think you started off by saying the role of government is important in this marketplace, and number one is safety, and you're clearly right. So we have to have a safe environment. That's why we have things in Washington called the FDA, which says this drug is safe or this device is safe. We have, at the state level, we have licensing for doctors. So you can't go to someone to treat you for something unless they have a license, so we're protecting you because you don't know if that person is good or bad, so the license at least says at minimum we protected you. So that's an interference in the market, but it's a higher calling because the consumer, the patient, doesn't understand a good doctor from a bad doctor, or a person saying I can do medicine, but a license at least gives them some comfort. That is a concept that has far-reaching implications, and it comes from the idea in economics of asymmetric information. And the role of government is very important in asymmetric information. It means essentially that the consumer doesn't know enough to make a good decision. Medicine is complicated, it's technical, and so the government has to say, in order for this market to work, for this consumer to buy, and the healthcare industry to sell, we have to equalize that information. Because the hospital and the doctor know a lot more about what they're selling and what's good and bad than the patient. So the role of government is to equalize it in the market and to say you need to have a license, the hospital needs to be certified and accredited, and we need to know that what's happening in there is safe and good for the patient and let them make their decision. So for the market to work, the government has a role, because otherwise consumers can't make good and rational choices in the marketplace. So That is often called asymmetric information. Some textbooks will call it market failure. The market will fail. That's why, as of course you know, we have lemon laws for cars. For example, it's sort of the notion that someone has to give the consumer a chance to change their mind if they find out the car isn't as good as it should have been, or if they buy a house and they were pressured in the way that they shouldn't have been. So to give consumers a fair chance in the marketplace so the market can operate better. So the role of government is often to help the market, to provide information and backing to make the market function better. And this is extremely important. So now, so far I've only talked about safety, externalities, market failure, and the market improving and getting the best outcomes, lowest cost, efficiency. But I started off by saying the market does not deal with equity. There's nothing in the market that's fair. It's not built into the market. And so the question is, what does fair mean? Well, in a civil society that we live in, fair means that people, we believe, as a common good, should have reasonable access to healthcare services. So access is always an important goal because the market doesn't provide that. The market just provides a bunch of things out there at different prices or different insurance coverage, but it's not necessarily fair. And so the role of government is to look at access and fairness, or sometimes called equity, which is another word for the same kind of thing. So you see a lot of arguments, and people accept someone should have access to a doctor, particularly a primary care doctor who can help them out in the healthcare system. Doctors should be located in some proximity to where they live. So that's the role of the government, to try to help things and make things more equitable. This has another term in public health. A lot of my colleagues would call this social justice. Equity, social justice. And the role of government is very important there, extremely important. And so the market does as good as it can. In healthcare, many people think there's a lot of market imperfections. Consumers don't necessarily know what the prices are. And even when they do, insurance is covering them. So I want to end my comments, I was told to be very brief, and hopefully I am, with just two areas that I think you might look into further that are going on in other states, which would be an outgrowth and a role of market, and I can provide this information to you later. So there are something like 12 or 15 states now that have what's called an all-payers claims base. All-payers claims base. What does this mean? That means that all the payers, Blue Cross, Blue Shield, Kaiser, HealthNet, you know the list of them in the state, provide information to either the government or some nonprofit agency that puts all this information together and compares their prices and gives the consumer some idea of what's going on. And and also can produce reports that will say the prices in Sacramento are 40% higher than the prices in Los Angeles. Why is this going on? We don't really have that. We have OSHPD, which includes hospitals, but OSHPD doesn't actually have the prices. They have the costs. Costs are different than prices because there's a lot of discounts. People get different deals, so you don't actually know what's being paid. So 12, 15 states now have, and most of this is mandated by the government. There are a few voluntary efforts, but it mostly takes the government to say, we need this information to make good public policy decisions, to spend Medi-Cal money appropriately, to have health exchanges work right. We need to know what the prices are. Believe it or not, we don't have that in California. We have no idea what things cost in various areas in the state. So if I don't, as a health economist, know what these prices are, clearly the consumer doesn't. So to help the market out, I think I would suggest that you look into, and I'm happy to send you some information on this on all payers claims base. The other area, and I'll end on this one, is the Affordable Care Act. Beyond the insurance coverage, which has gotten most of the attention, of course, and as it should, but in order to improve the delivery system, and that is lower the costs, or sometimes called bend the cost curve, you've heard that. The notion is that integrated delivery systems like Kaiser do better, bringing the hospital, the doctors, the primary care together. And so the version of that, more or less at the federal level, is called Accountable Care Organizations, or sometimes abbreviated as ACOs. These are another form of Kaiser. It has some other bells and whistles. I don't have time to go into the details unless you decide to ask me. But basically, it pushes and incentivizes doctors to get together to provide bigger groups for efficiency and effectiveness. But on the other hand, it also gives them more market power. And if they're bigger and they have a big share of the market, they can control prices in the market. So what's the response of government? The federal government is incentivizing these things to happen, giving money. They are happening. In fact, California is the #1 state for accountable care organizations in the country. Even adjusting for the size of California, it's huge. But we have no idea how this market's going to play out. So I think new regulatory principles need to be thought of. They need to be worked out. And when California does them, clearly the rest of the country will follow. So let me stop there and thank you.
Well, thank you, Doctor, and you've provided a great foundation. I think I would like to hear Dr. Rudolph, and then we'll open to our questions. I do want to welcome Senator DeSaulnier, as I mentioned earlier, former chair of this committee, who helped envision expanding our understanding of external economic impacts on state government and public health. So we will come back with some questions for you, Doctor. And Dr. Rudolph, welcome to you. MD, MPH, now working with the Public Health Institute, but nice to see you. Thank you for joining us this morning.
Thank you. Good morning. I really, really appreciate the opportunity to be here today. And I wanted to share with you some reflections based on my 3 decades of practice as a public health physician in local government, as a local health officer in state government, working for a labor union, and now working with the Public Health Institute, which is a large not-for-profit that spans the breadth of public health activities. I'm sure that in your role as legislators, you've heard a lot of arguments against the use of public policy for public health. Government shouldn't limit individual choice. People need to take responsibility for their own health. Don't interfere with the market. The science isn't settled. Don't act until we know everything. And public health regulations are bad for business. I'm not going to go through each of those arguments, but what I'd rather do is give a very brief overview as to why I think we need public policy to protect and promote the health of all. And other speakers that follow will provide a lot more detail. And there's basically 6 reasons. Health is important. The costs of poor health hurt the economy. Environments impact health and shape health opportunities and behavior. Market failures adversely impact health, and I won't talk about that as Dr. Scheffler just did. And there's tons of evidence that support the need and the effectiveness of public policy for health. So first, health is important. And I know that sounds obvious to everybody, but I think it's worth saying that health has innate value because good health makes it easier for us to pursue other things we want to do, like make a living, raise a family, spend time with friends, participate in community organizations, and so on. Health enables participation in the workforce and enables good productivity. Poor health affects the productivity not just of individuals, but also of caretakers. And poor health increases school absence, and good student health improves student performance. So the U.S. spends nearly 1/5 of its gross domestic product on medical care costs as opposed to health. And if we keep spending that much on medical care, it essentially saps our ability to invest in all of the other important areas that we want to invest in, like education or deficit reduction or renewable energy. Studies suggest that an investment of just $10 per person per year in proven community-based programs to increase physical activity, improve nutrition, and prevent smoking could save the country more than $16 billion annually within 5 years, which is a return of about $5.60 for every dollar spent. A recent study looking at CalPERS members suggests that if we could reduce common chronic conditions by just 1% among the 2.6 million current members of CalPERS, we'd get a savings of about $3.6 million a year. And there's a lot of support across the political spectrum for these kinds of investments in the health of our communities. A recent California field poll showed that over 75% of voters in small, rural, conservative counties in California agree that public investments aimed at keeping people healthy make sense and pay for themselves in the long run. Unfortunately, our health fares poorly when compared with other developed nations. Americans die younger, have poorer health across the lifespan than people in other incomes in other countries. Health inequities in California are striking, persistent, and frankly unacceptable. People who live in neighborhoods that are largely non-white, with high levels of poverty, low educational attainment, high levels of unemployment, and limited opportunities and resources for health, have higher rates of illness and injury and life expectancies that often exceed 10 years shorter than those that live in better neighborhoods. But even those of us who are relatively healthy, white, educated, and upper income, have worse health than our peers that are similarly situated in other countries. So the reasons for our poor collective health are complex, but key among them are that our environments have a huge impact on health. And many of us live in unhealthy environments, in areas where freeways or stationary sources of air pollution like refineries pollute the air, in small communities where there's still no safe drinking water in the Central Valley, near busy roadways that are noisy and dangerous, in houses that are dilapidated or have problems like mold, in neighborhoods where violence is common, there's no safe place to play, the local school is poor and offers poor educational opportunities, and the many communities where there's no nearby grocery store or where in order to afford housing, people have to spend hours each day commuting by car to get to work. Since I never go anywhere without talking about climate change, I will just mention that climate change will act as a threat multiplier for many of these environmental risks. Rising temperatures will increase ozone levels and the risk of urban heat islands. Drought will threaten our water and food supply and raise food prices, which will again most adversely impact those that live in the poorest communities. Collectively, the physical, social, economic, and services environments in which we live, work, learn, play, shop, and pray, and when I was the Berkeley health officer, we always added and have sex, constitute what we call the social determinants of health. They not only have direct impacts on health, but they impact our opportunities for health, our resources for health, and our health behaviors. When it's cheaper to buy soda or cheeseburgers than to buy non-fat milk or vegetables, people with a limited income have an incentive to eat cheap, calorie-dense, nutritionally inadequate food. When your child has to cross a busy roadway full of speeding cars to get to school in a neighborhood without good sidewalks, it makes sense to drive to school and miss that opportunity for incorporating physical activity into your daily routine. When children and teens are bombarded by advertising for soda, junk food, alcohol, and outlets for these products, although legal, surround them, or when people lack information about the true health costs of these products, as Dr. Scheffler alluded to, why would we be surprised that we have such high rates of obesity and chronic illness and such persistent health inequities? I'm not going to talk about market failures. So right now, even though experts agree that only about 15 to 20% of our overall health and longevity can be attributed to clinical care, and that the social determinants have a far greater impact on how long and how well people live than medical care does, the huge bulk of our spending goes to the top of this pyramid, the clinical individual interventions and individual counseling and case management and health education that occur in the medical arena. But the evidence suggests that it's the interventions at the bottom of the pyramid that have the largest impact on health. And this pyramid comes from Dr. Tom Frieden, who's currently the director of the Federal Centers for Disease Control. These environments, these social determinants of health, don't just happen by chance. They're shaped by decisions that are made by people like you, by governments, and of course by the private sector. But they're largely shaped by government decisions about things like what commodities will we subsidize. Like we subsidize corn, and we have a lot of high fructose corn syrup, cheap. Where do we put our transportation dollars? Do we put it into freeways, or do we put them into a bike infrastructure? How much do we limit emissions of air toxins or of greenhouse gas emissions? Historically, our greatest public health achievements have been through policy interventions in community environments. Sanitation, clean drinking water, reducing lead exposure, tobacco control, housing and building standards, seat belts. You'll hear more about some of these from other speakers, but these all reflect conscious decisions to make public policy interventions to promote and protect the health of the public. We're certainly not lacking for evidence as to what works to improve health and prevent obesity and chronic illness. And the evidence suggests many different ways that public policy can impact the social determinants of health. And again, other speakers will allude to these, but there's a whole range of options for what public policy can do to promote and protect health. I want to give you one example of how the deployment of resources outside of the health sector can impact health. So I mentioned that for years, our transportation dollars have gone primarily to highways and infrastructure to support moving people around in private automobiles. What if we made a conscious effort to shift people to active transportation, walking, biking, and public transit, by supporting a really robust walking and bicycling infrastructure that would give people true transportation choice that we don't really have right now? My colleague Neil Maislish at CDPH worked with the Bay Area Metropolitan Transportation Commission to model the health impacts of a very feasible shift to use active transportation for just 15% of trips, mostly short trips. He found huge health benefits on the order of those of our tobacco control program over the past 25 years. For example, a 14% reduction in heart disease, stroke, and diabetes, and these are among leading killers, as well as significant reductions in depression, dementia, breast and colon cancer, and so on. Offset a little bit by bike and pedestrian injuries increasing, which we could address by making sure that we created a safe walking and bicycle infrastructure. And with this kind of shift to active transportation, we'd also achieve almost a 15% reduction in greenhouse gas emissions. So I want to end with two suggestions about what I think are the most important things that you can do as policymakers to promote health and protect health for all Californians. First is to more consciously and conscientiously incorporate a health lens into your decision-making processes across the whole of government, not just in the health committees, but in the Transportation Committee, the Agriculture Committee, the Finance Committee, the Education Committee, and so on. Most of the decisions with the biggest impacts on health happen not within the public health arena, but in these other sectors. And I know that you both know these, and I really appreciate especially your support for this concept of health in all policies. But I want to see you take the next steps to actually make it a reality in California's legislative policymaking and budget and finance processes. We also need a more permanent source of funding for community and public health programs that we know work. We know what we need to do. We don't know everything, but we know a lot. But it can't happen without funding of local public health departments, of the state public health department, and of public health community-based organizations and NGOs like the Public Health Institute. We need a California Health and Wellness Trust that provides a stable and secure source of funding so that the programs that work aren't funded cyclically by dollars that dry up or move elsewhere every couple of years. So I'd encourage you to investigate mechanisms for establishing a California Health and Wellness Trust. Health is a collective concern, and it takes a collective response to improve the health of Californians. And public policy and government intervention are the mechanism that we have to actualize that collective response. So I appreciate, again, your holding this hearing and addressing this important topic. Thanks.
Thank you, Dr. Rudolph. Excellent overview and some of the comprehensive look at health in all policies and how transportation policy can affect public health and can be, we do have the ability to incentivize and promote healthier practices in all levels. I'm going to open it to questions now. I'd like to lead off, if I might, with a question for Dr. Scheffler. We're going to hear a lot about tobacco controls leading to better health outcomes, the use of tobacco tax to pay for public education. But Dr. Scheffler, you mentioned that the tipping point was really determining that it wasn't just a personal choice of smoking, but when there was evidence showing secondhand and broader community impacts or workplace impacts. Neither of you touched, I don't think, on the role of advertising. I recall as a child the tobacco commercials on TV. 9 out of 10 doctors in white coats agreed that Camel or whatever the product was the best. Yeah, I know, was the best. But those ads had an impact on me.
Oh, yeah.
And so the role in this free market that you pointed out is not exactly free. Not only do we have the challenge of getting good information to the public to inform choices, but how would you describe the role or the impact? Is there a way to quantify the impact of advertising in influencing those individual choices that may not be good choices from a health perspective?
Yeah, that's an excellent question. I think we're in the same generation. I do remember those ads, by the way. And unfortunately, those ads are quite effective, particularly for teenagers and the young 20s, you know, the image, the Marlboro Man, and et cetera, et cetera. So I think it's pretty common knowledge now that these ads are not good public policy in California, in the country, and also in other countries as well. So I think there's a massive worldwide effort to not allow these kinds of advertisements. It doesn't happen in all countries, but in many good democracies, this information is just not allowed, quite frankly. I think for good reason. Again, it's asymmetric information. The consumer really doesn't know what's being sold in that little packet of cigarettes, and we need to protect the consumer from injury and death. So I think there's a good public policy reason for that. The other reason comes about because when you get ill from smoking, we all pay for it. It's not only the individual paying for it, but if you're elderly and all those years of smoking, the Medicare program is obviously going to pay for that, and that's a tax out of everybody's salary. Or the Medi-Cal program, which is state money with federal money, I'm sure you know, we pay for that. But even private health insurance, if you decide to smoke, my premiums go up because we need to take care of your illness and the costs get passed on to me. So not only for public programs, but also for private health insurance, there's a negative externality in the sense that your bad behavior cost me money. So if you want to kill yourself privately and it doesn't affect the public trust, then that's one thing, but clearly in the case of smoking, it does.
Well, that leads to a follow-up question on, from an economist's point of view, when you identify these negative externalities, what tools do you have to measure that cost shifting either to government, Medi-Cal programs, Medicare programs, or private sector cost of private market health insurance? Are there metrics that allow
Yes,
you
yeah.
to measure that cost shifting?
Yeah, so there are metrics. There's very good studies. I'd be happy to send some on to you that look at the cost of smoking, not only to the individual, but society as a whole. And some of that's been done in California as well, but it's been done all over the world. So there are metrics, and basically what you look at is, of course, increased healthcare cost, which is what I suggested with my earlier answer. But then you very importantly talked about it's not just healthcare costs, but it's quality of life and lost productivity, lost years of life. There's very good metrics like that and data out on smoking. Of all the things we have good metrics on, it's the smoking impact. It's the number one killer of preventable killer in the world. And so people have studied it at all different levels, and I think we have tons of evidence that would support public policy in this area without any doubt. When you get to alcohol, it's a bit tricky because, alcohol has some positive health impacts too as well. A drink a day or two, depending on your weight. So it's more complicated. In the case of smoking, I think it's clear. It's totally clear. It's just something that's just generally not good for you. And then the metrics are there. I can send them on to you.
Thank you. That would be helpful, and we are going to hear from some other witnesses later today about some other specific kind of emerging or ongoing health risks that maybe do present more of a challenge of how we quantify that cost shifting. I did just want to ask Dr. Rudolph a question as well. You mentioned the standing of the U.S. vis-a-vis other countries, and are there any models of other countries that you're aware of where there has been a greater success in, for example, walking and biking or other public health measures that have resulted in higher, better public health?
There's a whole range of examples of other countries that have implemented policies aimed at increasing the share of people that use active transportation to get to work. And, Denmark comes to mind, for example, where even though it's a northern country that has a very cool winter, about 40% of people in Copenhagen now ride their bicycle or walk to work because they have an infrastructure that really supports that. There's also a lot of examples of other countries that have better health outcomes and less health inequities than we do, that have instituted a whole array of social policies that have led to those better outcomes. And I'm happy to share some of that information with you.
Dr. Scheffler referenced the Affordable Care Act, and I know one of the features of the Affordable Care Act, for all the current atmospherics at the national level, I think it's beyond dispute that one of the goals is to expand access to primary care, prevention, immunization, and reduce the most expensive access to medical care, which is emergency room access that usually working poor are using because they don't have access to primary care. Another feature is investing more in prevention and not allowing insurance companies to charge extra premium rates for prevention programs, tobacco cessation, et cetera. So there is an effort, as we're trying to implement now the ACA in California, to shift some of that huge national and state cost for the public aspect of that implementation into more access to prevention, primary care, um, primary care homes, et cetera. So there's a recognition, and the challenge is the heavy lift of within that market system achieving those benefits in a public health realm. I want to turn to my colleague, Senator Saulnier. I'm sure you have some questions or comments.
Both. Try to be brief, but I want to thank you, Bill, and Michelle, for the great staff work and having this hearing. Hopefully after this hearing, sorry, we've got technology between us, Dr. Rudolph, is that we could actually look at how we do prevention and intervention in this budget subcommittee and include it in our thought process. Bill, or Chairman Monning, had the soda bill, the soda tax bill. I had a bill that was more a reaction to prescription drug abuse. So some of my questions are about that as a externality, but is very much sort of crosses the line into internal operations of the health system. Dr. Rudolph's comments, I'd love to work with you on sustainable funding. As you may know, I carried the resolution, the Health and All Policies resolution that has staff working across these lines, and the good work that Dr. Jackson did when he was a public health officer about bringing the attention to the built environment, and certainly as chair of the Transportation Housing Committee, we'd love to do more of that. In response to the chairman's comment, not just, as you know, Copenhagen and Denmark, but in Holland, particularly in Amsterdam, where over 50% of the peak trips daily, both in Denmark or in Copenhagen and Amsterdam, are taken at least in part by bikes. And it's very different when you go there and see their rail system, where there are no parking lots in the subway rail systems, that people get there by walking or bike or transit. And if you could shift that cost, the cost that we put into parking garages in suburban commuter rail, and we can see that in DC, where one line of the metro line did that, another corresponding line in Northern Virginia did not. You can see the health impact. Similarly in southern Germany, where they have a robust pedestrian and bicycle infrastructure. So, but my comments are directed both at both doctors, but also for the future, for the rest of the agenda, and maybe for subsequent discussion. But one of the things that struck me at the local level when we were doing tobacco laws in Contra Costa County, when I was a county supervisor, and as a former alcohol licensee, and being struck by the fact that we have amongst the lowest taxes on alcohol in the United States here, and having tried to do with Senator Bell, when we were both in the Assembly, a nickel a drink, before Prop 26 made it more difficult to charge fees that would go back into prevention. But particularly on prescription drugs, and your comments, Doctor, about information economics, the work that Dr. Stiglitz has done about moving rent-taking further than what it's traditionally viewed as in the economic field, and particularly when it comes to information. So we know when we had those advertisements when we were young, that the advertising field and the market was sophisticated to know that particularly young people, their cognitive skills, if they were exposed to a doctor or a trust figure telling them this was okay, they were more likely to pay for that. So in the work that Janet Meslin did on Your Daily Meds, if you've ever read that book or some of her subsequent work, the whole idea that investors and venture capitalists knew the research that we now know about how people respond to stimulation, the front parts of our brain. I'm a poor old saloon keeper, so I've got an undergraduate degree, so I don't understand all this stuff. But all this information is going in the marketplace. So when you talk about information economics, it seems as if there's a distinct imbalance right now in fairness. There's so much money and research put into stimulating people to buy product between the media and information. But with all the good work we've done on tobacco cessation, it's a war we're losing right now. And in prescription drugs, over $1 billion is spent nationally. I think the statistic is the U.S. has 3% of the world's population, but we consume 80% of the painkillers in the world. And in Ms. Muslin's information, she saw where investors doing their job knew that pharmaceutical companies had a high level of trust in the 50s and 60s. They invested in those corporations and actually created marketing to get people to buy incontinence products that were approved by the FDA, but had very marginal returns. So my question to all the groups, and this goes to my favorite Madison quote, which said, if people were angels, there'd be no need for government. How in this new world of information economics, particularly in the public health field, do we try to balance this onslaught of very sophisticated marketing with information that, as we learn the cost of it, we can actually get young people not to want to go to three full meals of fast food, or people to go to the doctor to get Vicodin every time they've got a sore shoulder?
Well, I think you've asked the question that can't be answered, of course.
Oh, thanks.
But in the United States, I think you're aware that one of the few countries, I think Australia is the only other one,
New Zealand.
that has a direct consumer advertisement in healthcare, which is legal. It's not legal anywhere else. So you get magazines that parents read with ads for drugs, medications, therapies, all sorts of things. It's perfectly legal, and if we believe it's part of the market, and there's a long history in why we do that. So information is a funny thing. We want it out there. We want to have consumers informed about what the choices there are out there, and it's not all bad. I mean, somebody who reads that may find that their child has that, and asking the doctor about that medication produces a good outcome for their child. But others may be pressuring and finding the medication in the ways that isn't good for their children or them. So the answer is we can't, I think we can't argue against information. And the role of government is to make sure, of course, that it's accurate. And the FDA doesn't deal with that. The FDA just says it's safe, and it does what it does on the label. But it doesn't necessarily work for you, or it's good for you, or it's interactions, or that's not their job. So in the United States, we have a patchwork in the market. There is a role for the consumer and individual behavior to be able to make those kind of choices with help. And the strongest role for government is to provide reasonable, respectable, reliable, and the catchword now is evidence-based information. What's the evidence to make that claim? Where is it? Where does it appear in the science? Who's saying that? Is it something that we want the public to be able to take as truth? So I think that's the strongest role, and there are obviously pieces of legislation to move in that direction. This is clearly a longer discussion. I'm happy to have it with you later on, but I think you're on a key point of where this kind of tips. And we are concerned about it. I'll advertise. I happen to have a book coming out on the use of Ritalin and ADHD and the explosion of it around the country. In a few months, I'll send you an early copy, but a lot of it has to do
I'll have
with...
to declare it to several dozen government agencies, so I'll buy it.
Okay, well, I'll send you the website to buy it. So in any event, but the pressures for these things, you talked about having, various drugs. Some of it we need to understand, it's the culture of the United States. You're pressuring people to be productive. You're pressuring them to work hard. You're pressuring kids to get good grades in school, to go to college. And this has an enormous impact on people. In the case of attention deficit and Ritalin and Concerta, it's pressuring parents to have their children take medications. So it's a big problem in the United States, and there's a reason why that's happening. It's not just the drug companies. There's a whole notion of productivity, performance, the push, school exit exams, all sorts of people are tied up in doing better and better, and the healthcare system provides, some drugs and help along those lines, and I think we need to be concerned about that.
I think, Chair Monning, I think your question about advertising and how it's evolved is something we should talk more about. And to the degree you can help us with what's fair in terms of what the the consumer gets and how they're motivated to purchase things that may be unhealthy, that there's a commonwealth investment in changing that, that would be really helpful for us, I think. And there's been legislation to copy what Washington State, I believe, does, where they work with the University of Washington to create a website to truth test drugs coming onto the market. I haven't been able to get that out of the Health Committee in either house, but maybe that's something we can talk about.
Okay, let's
At
do
least
that.
there's a resource for people to go and say, the FDA's approved it, but this is what the research has said, this might be impactful to you.
So when they Google, they get 3 or 4 websites they can go to, including that one.
Thank you. I think Dr. Rudolph maybe had a comment on
I just wanted
this area
I
as
just
well.
wanted to comment that the tobacco control program has been very successful. In 25 years, it's saved about 1 million lives and about $86 billion in healthcare costs in California. And it did that with a multi-pronged strategy that included restrictions on where people could smoke. But it also, a key part of that was really a counter-advertising and social marketing campaign, because advertising does work, but we can also advertise if we have resources to do so. And the other thing I think that's really important is to hold these various manufacturers and others accountable for telling the truth. I don't know exactly how to do that, but I don't know if you're familiar with the book by Naomi Oreskes called The Merchants of Doubt, where for tobacco, for greenhouse gas emissions and climate change, there's been a whole industry of people that are trying to sow doubt about what is actually very solid evidence about the health and other impacts of some of the products that they sell.
Thank you. In the interest of time and our other panelists who are here, I do want to thank you both. I hope you'll be able to stay and listen to some of the other contributions, but thank you so much
very
for
much.
helping lay the foundation for this hearing today. We look forward to ongoing work with you. And we'll move now to our second panel. It will be our Director of California Department of Public Health, Dr. Ron Chapman. And as Dr. Chapman works his way up here to the dais, he'll be the only person on this panel, and then he'll continue with the next panel, who I will invite up after his affirmative testimony here. His subject, the trend and burden of chronic diseases and injury in California. So we go from kind of the foundational or maybe more theoretical look at externalities, negative impacts on the public, on health, to maybe a report card on some of the current risks and trends in chronic disease in California. Dr. Chapman, welcome. We appreciate your taking the time to join us today.
Thank you, Chairman Monning, Ron Chapman, Director and State Health Officer. Really, truly appreciate your support and interest in public health. I'm going to talk about the trend and burden of chronic diseases and injury in California. Do want to share with you the burden of chronic disease and injury report that the department published this year. It's on the CDPH website, and you have a copy in front of you. My presentation highlights some pieces from the report. Just want to briefly read the beginning of the report. States California's health landscape has evolved dramatically over the past 100 years. In 1910, pneumonia, tuberculosis, and diarrhea were the leading causes of death, and the average life expectancy was 47 years. In 2010, the leading causes of death were heart disease, cancer, and stroke, and the average Californian lived to 81 years. Overall, Californians are living longer, healthier lives. Improvements in housing, sanitation, drinking water, nutrition, working conditions, and advances in education and preventive clinical services such as immunizations have created conditions that prevent many infectious diseases and injury. To realize such remarkable accomplishments, public health joined with urban planners, educators, engineers, health professionals, policymakers, and thousands of concerned Californians from all walks of life. Despite these extraordinary successes, more remains to be done. Millions of our friends and loved ones are living with and dying from chronic diseases that are preventable and treatable. Additionally, too many Californians do not have the same opportunities to be as healthy as others. So again, the report is on our website. The cost of disease in California is staggering. This is all of healthcare cost spending in 2009, a little over $230 billion, accounts for 12% of the state GDP. The government's share of that spending, 22% in Medicare, 70% of the total in Medi-Cal. The per capita spending for all people over $6,000, for Medicare $10,000, Medi-Cal $4,569, and there you see data on health spending growth trends in 2009 for all of healthcare 4.5%, Medicare 7.4%, and Medi-Cal 9.8%. This comes from the California Healthcare Foundation's Healthcare Almanac. Leading causes of death in California from 1996 through 2010, and again, this is highlighted in the burden report. The red line on the top is heart disease. You can see the clear downward trend. The next lower line, the green line, is cancer. And then below there, you can see stroke and the remaining causes of death, such as unintentional injury, Alzheimer's disease, diabetes, and influenza and pneumonia. Leading actual causes of death in the United States in 1990 and 2000, 1990 being the blue bar, 2000 being the red. You can see, as the previous speakers and yourselves noted, tobacco leads the pack, so to speak. Poor diet and physical activity is next. And you can see that actually poor diet and physical activity as the leading cause of death, the percent increased significantly from 1990 to 2000. Alcohol consumption, then microbial agents, toxic agents, motor vehicle collisions, firearms, sexual behavior, and illicit drug use on the bottom. Expenditures on the four most costly conditions. You can see again, blue line is 1997, red 2009. Significant increases across the board: heart disease, trauma, cancer, and mental health. This again comes from our report. This is the share of adults with one or more chronic conditions by county. And you can see the great distribution across the state. The darker blue is the range of age-adjusted prevalence or percentage of chronic conditions in adults in that county, the dark blue being 40.8 to 46.2, and the lighter color being the lowest. And then LA County is also broken out by planning areas. The lowest prevalence being, as you can see, those white areas along the coast. The cost of chronic disease in California: 7 common chronic conditions: heart disease, cancer, stroke, hypertension, diabetes, mental disorders, and pulmonary conditions, which shorten lives and reduce quality of life. Economic impact, $133 billion. Treatment cost, $26.9 billion, and lost productivity accounting for $106 billion. This is from the Milken Institute report from 2007. And of course, as we've been talking, there is a huge value of prevention. Preventing and managing chronic disease and injury can reduce future economic costs of disease, and improvements in health increase investments in human and physical capital, driving additional economic growth in future generations. So now I'm going to highlight a couple of specific diseases. Obesity is first. And as we know, obesity has risk factors, is a major cause of death, including those risk factors: poor diet and lack of physical activity. In the poor diet category, we have identified, we know of areas, communities in California where there are food deserts. These are areas where the people living in those communities simply have no access to healthy foods. We know that sugar-sweetened beverages are a major contributor in this poor diet category. Just want to turn your attention to the Let's Get Healthy California report, which the governor, through executive order, and the secretary brought together a task force and identified 39 indicators that we are tracking, monitoring, and hoping to improve over the next decade to make California the healthiest state in the nation. And many of those indicators revolve around physical activity and nutrition, indicators such as vegetable and fruit consumption, and soda and sugar-sweetened beverage consumption. And as we know, obesity leads to heart disease, diabetes, stroke, and a number of cancers. In California, 35.3% of adults are overweight, 25% are obese. You can see that both Black and Hispanic Californians have significantly higher rates of obesity than white Californians. And Californians with less than a high school diploma have twice the rate of obesity than those with a college degree. This is clearly demonstrated in this graph, which shows the health disparities by race, ethnicity. These health inequities cut across all chronic diseases. The underlying factors here are the social determinants of health that have been talked about: poverty, education. It's all about the environments where people live. This is child obesity among participants in the CHDP program, the Child Health and Disability Prevention Program, from 1993 to 2010. I have been asked in my 2.5 years on the job if there's anything that keeps me up at night, and I'm actually a pretty sound sleeper, but this graph keeps me up at night. That's just heading in the wrong direction. This is the fitness gram, changes in overweight and obesity among Californians 5th, 7th, and 9th grade, 2005 to 2010. This is a very colorful map of California. What this shows is the percent change in the fitness gram, which is a test of the fitness level of 5th, 7th, and 9th graders in 6 different areas, such as pull-ups, hanging from a bar, running, walking times, curls, abdominal curls, flexibility. And what this shows is in the green, those counties that had a percentage change 2005 to 2010 at least 3% lower in 2010. In the dark, the fitness gram went worse. Yes, their fitness gram scores were lower. And in the pink to red, I don't know if that's exactly red, but I'm terrible with colors. This is at least 3% higher in 2010. And this what this map shows is it is literally all over the map. There's no consistency here with the fitness gram. Some counties are improving, some are going down. Again, all over the map. Obesity attributable expenditures by payer. You can see Medicare, $3.4 billion, Medicaid, $2.8 billion, and state overall, $15.2 billion attributable to obesity. Next, I want to talk about type 2 diabetes. This is unpublished data from our 2013 California Diabetes Burden Report. 2.4 million, or 8.6% of all adults, have been diagnosed with diabetes in California. That's 1 in 12 adults. 5.2% adults are projected to have undiagnosed diabetes, and more than 11 million adults are estimated to have pre-diabetes. Diabetes in pregnancy has increased by 60% from 1998 to 2005. And here's the graph showing the diabetes trends in California. The red line is the United States, and the blue line is California, of course, going in the wrong direction. This is by county, showing diabetes prevalence in California counties. The red is the highest with between 8 to 10%, and the light whitish areas are from 5 to 6.9%. Cost of diabetes exceeds $24 billion each year in California. Again, this is from our unpublished 2013 California Diabetes Burden Report. Direct medical cost at $18.7 billion, indirect at $5.8. The average annual treatment cost per case for diabetes diagnosed in the U.S., nearly $10,000 in 2007. The last area I want to cover is injury and violence. Again, you'll find this data presented in our burden report. Leading cause of death for people ages 1 through 44 in California, with 16,569 deaths from injuries in 2011 for all ages. This is one person dying every 32 minutes in California. Over 250,000 hospitalizations, an estimated 2.1 million people treated in emergency departments, and injury and violence cost more than $48.6 billion in medical care and lost productivity each year. And here is a graph showing the trends from 2002 to 2011. The blue is the frequency, so you can see the left axis is the frequency. This is the actual numbers. The red on the bottom is the rate per 100,000 people, and the rate axis is on the right side. But this really masks what's going on underneath. Here, for example, when you pull out the data on suicides from 2002 to 2011, you can see significant increases. Here's unintentional poisoning deaths. Again, the curve going in the wrong direction. Here's unintentional deaths due to falls. And at this point, you're probably asking, well, why did the overall curve seem to be going down, whereas all these curves underneath are going up? And here's one piece of the evidence. Homicides have gone down since 2002. And unintentional motor vehicle related deaths have significantly been reduced since during that time frame. That is my presentation on the trend in burden of chronic diseases and injury in California.
Thank you. Any explanation why the reduction in traffic and gun violence or homicides?
Go back here. So I do not have an explanation for the homicides. I can get you that information. I don't know if any of my staff here have an explanation.
Yeah, we can follow up. I'm just
Barb Alberson will be up shortly.
great.
We actually don't have a very good answer.
Oh,
We think
there you
it's
go.
tied to the economics, but it's something we welcome and relish, and there's a lot more we need to do. It's one of those anathemas we really can't
Yeah.
get back on.
And I know law enforcement data affirms that decline in violent crime, but I'm just curious some of the attributions for why. But with that foundation and this report, which I recommend to people, again, it's on your website, California Department of Public Health, The Burden of Chronic Disease and Injury, California 2013. So I recommend that people take a look at that. It's a very good compilation of current trends and data.
Thank you.
And with that, any questions for the health officer?
It'd just be helpful if we could get the information on your injury and violence in California. If you have any further breakdowns, for instance, where alcohol and drugs were involved, my recollection is about a third, or where other behavioral health indicators like domestic violence over multiple generations. And then on the, Doctor, on your second slide, just the healthcare spending slide, the share of GDP, be interested to see how those figures in that percentage compares to other developed economies. Those
Great,
two
we can
things
do
would
that.
be helpful.
Definitely. Happy to do that. Thank you.
Great, well, thank you. So why don't, Dr. Chapman will stay with us, and then joining him, if the next panel wants to come forward, looking at effective and successful public health laws and programs, we'll be joined by Barbara Alberson, Masters of Public Health, Senior Deputy Director, Policy and Planning, San Joaquin County Public Health Services on injury prevention policies. And then Government as Protector of the Public Health, we're joined by Andrew Shaney, CPhil Research Director, Berkeley Media Studies Group. So welcome to you both, and I think, Dr. Chapman, you're scheduled to lead off on this on tobacco control program.
Yes. Appreciate the earlier discussion on tobacco, so I will just jump right in. The California Tobacco Program goal was to change social norms, the outcome being preventing people from initiating smoking, and cessation, stopping people who are already smoking. The social norm strategy is about creating an environment where tobacco use becomes less desirable, less accessible, and less acceptable. And how we have accomplished this is a combination of media and community engagement, which translates into social norm change. I think this is a simple slide, but a very powerful and complex formula in terms of its implementation. The media, for example, is a very costly proposition. It takes substantial resources to be successful with a media campaign, and community engagement is all about local policies and empowerment of communities to create the social norm. The role of media. It's important for us to be ahead of the wave in terms of public opinion, and to use the energy at the front of the wave to pull public opinion forward. The role of the community. Did you like that slide? Yeah. Yeah. Role of the community is about amplifying the media message. It ties to programs at the community level. It involves expertise, influence, and connections, and results in the policy change that we've been talking about. And here's one of the slides that helps me sleep at night. This is California adult per capita cigarette pack consumption and smoking prevalence 1980 to 2011. In the upper line, you can see the United States minus California. The lower line in orange is California itself. We are very much ahead of the nation. Our overall smoking rate's about 12% in adults, second lowest in the nation. I believe it's Utah. Here's the smoking prevalence amongst California compared to the U.S. minus California. So again, green is California on the lower, orange is United States minus California. This is percentage of adult smokers. This is the 30-day smoking prevalence for California and United States high school students, and U.S. high school students in green, California in orange. 9th through 12th grade, you can see the downward trend, and again, California leading the nation. This is what we're always striving for. This is the health outcome of our successful anti-tobacco campaign in California. This is lung and bronchus cancer incidence in California versus United States minus California, 1988 to 2009. The green curve is U.S. minus California. Orange is California. We have seen a reduction in lung and bronchus cancer over this time frame 3 times faster than the rest of the United States. And during this time frame, have seen a 30% reduction in lung and bronchus cancer. So here's the ROI, the return on investment. Reduced cigarette consumption by 72%, decreased adult smoking prevalence by 46%, decreased high school smoking prevalence by about 50%. I mentioned the lung cancer rates. Estimated saved 1 million lives and averted $134 billion in healthcare costs during that time. That's the good news. The bad news is we still have a lot of work to do in tobacco. Because of simply the size of our state, we still have pretty much the largest number of smokers of any state in the country. We still have millions of people smoking in California, continuing to contribute to healthcare costs in terms of cancers and heart disease and stroke. In addition, we see the continued creation in the marketplace of new products, such as snus, S-N-U-S, which is a small little chewing tobacco pack that does not require spitting. So kids can sit in classroom and cheek and gum and nobody knows. We also are seeing an incredible rise in the use of e-cigarettes. And I was at a meeting with the CDC director just last week, Dr. Tom Frieden. He was sharing the success of their recent national campaign, the first ever anti-tobacco media campaign from CDC. And they're very proud of the results. They helped 100,000 people quit during this very, very hard-hitting campaign. But he was clear that there is still a lot of work to do and a lot of threats that continue in that realm. Thank you.
Thank you. I do want to get to the other panel members, but just real quickly, you cited Prop 99, so that was voters supporting this rule, but your equation was media and community engagement leading to these beneficial results.
Correct.
What's government's role in that media and community engagement?
So government's role is multifold. We in California, we actually create and run the media campaign. State of California, Department of Public Health. We work very closely with local organizations and local government to create and implement the policies that have regulated the use of tobacco and kept people safe and protected people from secondhand smoke. And so there's a role for government at a state level and local level.
Right. And so that Prop 99 revenue in part has been used to pay for the media
Correct.
outreach.
Yes.
And other community outreach. Thank
Correct.
you. Let's move to the to Dr. Alberson, injury prevention policies. Welcome.
Thank you for making me a doctor. I'll take that, if you will.
I guess you're a master.
I am definitely a master.
Great. Right.
Thank you so much for the opportunity to be here today. I have to say I'm a public health zealot, and my little heart is just so full of pride with our tobacco program as well. But I want to talk to you about the successes in the field of injury prevention. And I am now with the San Joaquin County Public Health Services, but I spent nearly 24 years as a section chief in the Injury and Violence Prevention Program under the Department of Public Health, starting their injury program from scratch. And it's a very comprehensive program. It is both unintentional injury like toddler drowning and senior hip fractures from falls, as well as violent injuries such as child maltreatment, domestic violence, and suicide. And we've enjoyed many, many successes over the years, but we don't go it alone in injury prevention. Everything is teamwork. We work with other partners in the government sector, with citizen groups, and lots of folks in the private sector as well. And as Dr. Chapman stated, we are a major injury is a major problem, but I want to frame it slightly differently. I think we are the biggest and least recognized public health problem in the nation. Injuries affect everyone. They kill more young people than all other causes combined, and continue to be a major cause of death and disability across the age span. You know, it's taking a card from the advertising agency to tell a story. Just think about the devastating life changes that result when a young person with a gunshot wound suffers a spinal cord injury. It's going to cost the public sector at least $4 million to take care of its medical and custodial costs over the next 40 to 50 years. The good news is that injuries are both predictable and preventable. There's science to what we do. We're data-driven and know what works to reduce risks. There's plenty of naysayers who deplore new policies and programs introduced to reduce the burden of injury, but because our consequences are so immediate and so deadly, the controversy usually dissipates fairly quickly and new social norms come to bear. And here's just one of many examples. In the early 1990s, injury epidemiology described how toddlers drowned when they had access to a backyard pool. The public health advocates sought a requirement for four-sided pool fencing to keep curious toddlers safe from harm. Well, the pool industry was very unhappy. Their lobbyists fought against exacting a state statute for pool barriers, stating that this law is very unnecessary. Adult supervision is all you need, and this is the parent's role. Get out of our way. Well, our answer was yes and no. The public health data brought forward horror stories where parents were supervising their toddlers, but there's a slight gap in attention to turn on a garden hose or to answer the door, and that's all a 2-year-old needs to scurry into the pool and to drown. Well, there was a stalemate at the state level, but the issue did not die. Interest at the local level kept growing into a groundswell, and as a result, some 24 local ordinances were enacted in very rapid succession, and there were many more in the pipeline. At that point, the pool industry caved. They did not want to have many local policies, each of them with their own rules and each of them with their own way of doing business. So today that controversy is largely dissipated. In fact, the pool industry often touts barriers and safety features in their marketing strategy. Protecting children from harm is good business. Others in the business sector, such as realtors, also got on board. United Multiple Listings now indicate if there's a pool fence when they're offering a house for sale. So what does success look like in terms of cost benefit? In injury prevention, we're mostly talking about cost avoidance rather than cost savings. The best outcome, of course, is when we prevent injury in the first place. Governmental intervention can lead to reductions in injury rates in real time, and that doesn't happen very often, but when it does, it's incredibly exciting. We saw this with the introduction of child-resistant medicine bottles. With that, we got a very rapid drop in toddler aspirin poisonings across the country. We're now starting to see it with attention finally being paid to sports-related concussions and brain injuries. California's injury data and prevention programs were at the forefront of this work. We started from scratch with a very small investment. But as the prevention and management of concussions becomes standard of care, we anticipate that we're going to save many more productive lives and avoid untold millions in healthcare costs. It can be difficult to pinpoint similar declines when we're talking about violence prevention, which is much more complex and challenging work, as you know. We rarely worry about the free market here. It's not government overreach since there isn't any competition for this job. Here, the role of public health is often behind the scenes. We work with partners to empower communities so they can make a difference. Here, a win could be addressing a root cause of violence, such as funding a community coalition in a very poor neighborhood that takes back a local park from drug dealers so that their kids have a safe place to play. That's a huge win, but it's hard to put economic costs to that. Traffic-related injury prevention, which remains one of the leading causes of injury death and is the most expensive injury category for Medi-Cal, offers many successes. Here, government interventions are the norm and work well. Laws and programs that were controversial when first introduced are now a given. We've seen death rates fall substantially over the last 3 decades as a result of comprehensive efforts that include technology, engineering, policies, and community education to change attitudes that create safer behaviors. One traffic-related prevention policy that's caused much commotion is the motorcycle helmet law. Anti-helmet bikers argue that helmet requirements limit their personal freedom. True enough, but nothing curtails personal freedom more than a devastating head injury. I really do think that a young survivor who thought he was invincible and is now living with the painful consequences, if he had an opportunity, he would do a do-over and wear that helmet. Motorcycle helmets offer a very clear example of how protecting the few benefits the many. In 1991, California enacted its universal motorcycle helmet law based in large measure on public health epidemiological data on crashes. Within 1 year, the number of motorcycle crash fatalities decreased by 37%, with a concomitant drop in Medi-Cal expenditures for the treatment of brain-related injuries. Child passenger safety, specifically for youngsters through age 7, illustrates another arena where we've been truly helpful in making a difference. California has strong statewide policies. We require youngsters to be buckled up in a car seat or a booster seat to age 8. We also direct a portion of fines generated by car seat violations. They go back to local health departments. They use these funds to coordinate with local law enforcement, educate the communities, and even distribute seats to low-income families. A little over half of the children hospitalized for motor vehicle occupant injuries are on Medi-Cal, and from 2006 to 2011, these hospitalized injuries for Medi-Cal and other children fell 50%. Thus, by just applying existing safety measures, California has slashed severe injuries and state costs in half in just 5 years. Is it nannyism? Kids didn't used to automatically get put in car seats. Parents couldn't buy them or afford them. Cars didn't accommodate them, and our culture didn't support them. It's the norm now. Manufacturers now put built-in car seats in minivans to gain market share. I would be very remiss if I didn't mention senior falls. No injury competes with falls in the elderly for hospitalization costs and mortality. More than 70,000 older adults are hospitalized every single year in California because of a bad fall. It's a broken hip if it's mom, and it's usually a brain injury, traumatic brain injury if it's dad. He's climbing trees. About half of these seniors are never able to live independently again. Whether it's in-home supportive services or a stay in a skilled nursing home, it can quickly become a Medi-Cal expense. And for those who are 85 years and over, some 2/3 are discharged to a long-term care facility, and these are our most fragile folks, and at least half of them die within the year. Elder Falls is a perfect example of where government interventions, where public health and medicine can cooperate to save lives, achieve prevention, and reduce healthcare costs. We have decades of demonstration projects that tell us exactly what we need to do. It requires fall risk assessment, a review of meds, and exercise programs like Tai Chi that improve lower limb strength and balance. Public health has worked closely with the Aging Network to build local capacity in fall prevention. For example, several years ago, using a federal grant, we launched a small-scale project that was done by local public health nurses in concert with their local agencies on aging. This was not unwelcome government intervention. Seniors vied to participate. They were afraid of falling and knew that this was the path to feeling more secure. And it worked. UCLA's evaluation of our project showed that there was a 50% reduction in falls among the seniors who participated in that program in the year subsequent to the program. Injury prevention successes are often embedded in collateral benefits. Creating walkable communities is a public health priority that demonstrates the melding of safety and health. In fact, few changes in society would more efficiently change our injury and chronic disease risk patterns more than walkable and bikeable communities. Improvements in physical activity, community cohesion, reductions in traffic, air pollution, and fear of street crime would all result from this back to our roots way of building our communities. I really do believe this is public health at its best. An older but still famous federally funded bike helmet project we conducted illustrates how an entire community can come together to support an associated state law when we're talking about walkable and bikeable communities. That policy, which was and still is the most stringent of its kind in the country, requires all youngsters up to age 18 to wear a bike helmet. The impetus for enacting this law was hospital-based research that showed that bike helmets are 85% effective in preventing serious head injury. Well, with our funding and a little bit of technical assistance, the residents of Pittsburgh saturated their town. The local health department, as well as parents and schools and businesses and churches, healthcare facilities, police, CBOs, all did their part in encouraging helmet use. And the results sang. With the helmet use among young people went from 24% to 72% in just 1 year. And we have a number of successes like this one, for which I can provide information if you're interested. Safe routes to school, traffic calming, pedestrian safety, crime prevention through environmental design, and many, many more. In summary, there's many dangers in everyday living. We don't want folks to live in fear, but we also don't want to wrap them up in cotton wool. We focus on what works and what we can substantially reduce the risks for so that life can be better. Often, injury prevention is most effective in protecting from harm those who don't understand the risks. Think that young man who thinks he's invincible. Think that toddler who crawls out the pet door and falls into the pool. It also works well when people do understand risk but don't know what to do about it, like the senior who's afraid of falling and she won't leave the house anymore. In large measure, we don't compete with a free marketplace. Safety sells as a public health concern. And in arenas such as Senior Falls, the tsunami of aging baby boomers will soon make more public-private partnerships an imperative. Demand is going to far outstrip governmental resources. We need both the infrastructure and the leadership to take this kind of injury prevention to scale. Thank you so much for the opportunity to present.
Thank you for your compelling testimony and your dedicated service in this area. And I think you raised the term of nanny government. I think there's no better examples of the adverse cost shifting than you cited the motorcycle helmet or the safety restraint seats for infants in cars. Every one of those prevented injuries, also protected public entities and the public from assuming the cost of, in some cases, lifelong medical care, medical requirements. So thank you so much. We will come back with some further questions, but I do want to get to Mr. Cheyenne, the research director with the Berkeley Media Studies Group. Welcome.
Thank you so much, Chairman Monning, and thank you, Senator DeSaulnier, for giving me this opportunity to speak. My name is Andrew Shane, and I direct the research program at the Berkeley Media Studies Group, a project of the Public Health Institute. It used to be Cheyenne in the 90s, now it's Cheney, it just sort of evolves with the times. But for the last 20 years, at Berkeley Media Studies Group, we've been investigating public health issues in the media, examining how the stories that are told characterize the role of government, including other issues of health. And what we've learned is that it's hard for the average person to see the government's essential role as the protector of public health. So I'm happy to be here today, not only as a public health researcher to share what we've learned, but also as the father of a 6-month-old son, as that experience has given me newfound appreciation for the government's protections we all enjoy. I'm certainly seeing the findings from our research through a new lens, to say the least. I'm especially happy to be here today because this hearing is very important on an issue that is often taken for granted. It's absolutely vital for public officials to take leadership as stewards for a healthy society. Our topic today is all about that. Let me tell you a brief story about why this is from one of the most valuable lessons in the history of public health. This story is about the fact that gathering support for any policy change, let alone those that are bold and controversial, takes time. Consider the state of New York, which just 3 years ago proposed a penny per ounce tax on sugary beverages. That effort failed, but in the same session of the legislature, lawmakers added a $1.60 excise tax on cigarettes that is credited with dramatically reducing smoking rates and healthcare costs, as we've seen here as well in California. Why would New York legislators levy $1.60 on tobacco but balk at 12 cents on a can of soda? Well, the answer has a hard-fought history. For nearly 50 years, public health has pushed for policies to put warnings on cigarette packs and advertisements, remove vending machines, mount educational campaigns, ensure smoke-free air, and institute tobacco taxes, all of which are evidence-based interventions that lower smoking rates and improve public health. But it wasn't always that way. In the early days of tobacco control, proposals for taxes met the same fate as New York's soda tax initiative. But strategies like taxes, with far-reaching potential, warrant continued attempts. Given our tobacco experience, we know that it will take more than one attempt. Therefore, even though public health didn't win that round in New York, I'm heartened by this effort. Because the more a policy is proposed, the more people have a chance to discuss and understand it. Policy proposals create opportunities for news coverage that helps set the agenda for public debate. Now, these discussions reflect some criticism for taxing sugary beverages, but each new attempt also gives people the opportunity to communicate the fact that someone, and as policies attempt Mount in Richmond, El Monte, and elsewhere, reflect the fact that growing numbers of someone support the policy. This movement helps set the stage for the day when it is a given that these beverages do damage to our society and government needs to protect the public's health from that harm. Perhaps one reason it takes so long to achieve these policy victories is because the news, the institution so important for helping the public and policymakers understand public health issues, is not always telling the whole story about the importance of government successes in protecting our health. I've heard obviously many today. But instead, research shows that the way the news tells stories means that news consumers often focus on individuals and their actions rather than on the role of institutions like government. When new public health initiatives are proposed, they often create controversies that easily generate headlines. But long after the attention dies down, the benefits to public health and safety that these policies produced become normal and expected and can fade into the background of society. They aren't newsworthy, so the public doesn't get the story about what is working. No one wonders where the non-smoking section of the airport is anymore, or bemoans the fact that children can no longer purchase cigarettes from vending machines. Even I can remember that. Or complains that an airbag saved their life. No new parent would leave the hospital without her newborn tucked safely into a car seat. We simply take it for granted. And not only are we able to take these protections for granted, but news coverage reinforces this idea by focusing on the notion of rugged individualism, which presents problems or accomplishments as the result of personal choices, while minimizing how social forces and public policies shape people's lives. This matters for government's ability to protect public health because it makes it much harder for the public to see how government or other institutions are a critical part of the solution. Let me give you just one example. At the Berkeley Media Studies Group, we've studied the origins of personal responsibility arguments in tobacco control, an area, as we've heard, where public health has made strong gains that have been made through government actions, even while the tobacco industry has poured millions of dollars into fighting these ideas. But by examining the first national fights over tobacco regulation, we found something quite extraordinary. In the 1950s and 60s, the tobacco industry did not question whether the government was accountable for protecting the public's health. Instead, when it became clear that cigarettes harmed health, the industry did not attack the idea that government had a protective role, as is so common today. Instead, industry voices were part of the many who said that if there is a health harm, government has a role to play in solving it. Therefore, despite its intensity, the attack on the responsibility of government is relatively recent. It has not always been a prominent feature of our political landscape. And thus, it is important to reinvigorate enthusiasm for sensible policies that provide broad social benefits. New policy proposals generate debate and news coverage that often evokes the question, what is the government's proper role in ensuring a healthy population? Our research consistently finds that the news often tells an incomplete story that hides the many ways in which government effectively protects the public's health, and we know that there are many. The government is a source of information to help individuals make healthier decisions, from warnings on packages of cigarettes to cancer disclosures on buildings in California, thanks to Proposition 65. Government takes population-wide actions to boost health, such as iodizing salt or mandating immunizations. Government enacts rules to protect individuals from preventable harm, such as zoning and emissions regulations limiting exposure to industrial pollutants at the Port of Oakland, or blood alcohol from the dangers of intoxicated driving. Subsidies for low-income seniors to have affordable telephone access through the Lifeline program enable our elders to live independently much longer, along with the safety to reach help in times of need. Public health has worked with public works agencies to build sewage and sanitation systems that reduced infectious disease and simultaneously reduced rodent populations and prevented flooding. Public health also worked with transportation agencies to introduce seatbelts, safer road designs, and other innovations that together have led to major declines in the rates of automobile crash deaths, some of those data we saw recently. And we know that building bike and pedestrian infrastructure creates more jobs, decreases air pollution and greenhouse emissions, and increases physical activity, all of which improves health and academic performance for students. I'd like to conclude by illustrating the importance of making government visible by telling you about the birth of my son, McEwen. Having a natural childbirth was important to my wife and I, especially her. So we stayed at home as long as was manageable before going to the hospital, something made possible only by the government system of maintained and financed roadways. We were fortunate enough to have a hospital experience that promotes breastfeeding, the single most important health advantage one can confer on a new child, which may soon become a reality in all California hospitals, thanks to SB 402. We brought the baby home in a car seat and vehicle designed with safeguards to ensure that our precious cargo was as well protected as possible. That's an improvement from government policies that's happened in my lifetime since I wasn't brought home from the hospital tucked safely in a car seat. My wife and I were each able to take time off of work to care for the baby, thanks to state disability and federal Family and Medical Leave Act policies that prioritize bonding with newborn children. Our transition back to work was of course difficult, but made much easier knowing that our child care provider was following rules and properly licensed with county and state rules for best practices. His health is already building from the state mandated and subsidized immunizations, and we're looking forward to his first flu shot this week. Going forward, we know that our journey as parents and his path and his health as a growing boy will be touched by government for years to come, including the availability of the clean tap water he will drink, the public education from kindergarten to post-secondary we're sure he'll achieve someday, the now healthier meals and drinks available in schools, and the safety features of the cars he'll drive. The list could go on, but I can't bear to think even that far in the future. Leadership and innovation aren't always easy, but we owe it to the people of California to work together to find the best ways to solve complex problems. Government support, which is our mechanism for pooling our talent and resources, will help us do that. Our democratic system requires two things, not only for public servants to be responsive to the needs of the citizenry, but also for citizens to be active and to petition our government with demands. From this perspective, an initiative to protect public health that emerges as a community concern and becomes a legislative proposal reflects the fact that government is each and every one of us and provides a structure for addressing shared needs. I thank you for investigating this critical issue, and I urge you and your colleagues to continue to lead the state to a healthier future for all our communities.
Thank you, Mr. Shane, and appreciate your close using your own experience. What's your new son's name?
McEwen.
And
Also hard to spell and pronounce.
Right. Well, you said you and your wife were looking forward to the first flu shot. You didn't say whether he was looking forward to the first flu shot.
Baby Tylenol is a miracle.
Thank you. Well, thank you all. This has been a great panel. Senator DeSaulnier, any questions? Again, I think the theme of this in all of your presentations has illustrated public health benefit, first and foremost, health and saving lives, the quality of life, and secondarily, but important, reducing the cost to government, to taxpayers, and then not always a government cost, but a societal cost as well that is reduced when there are successful and effective interventions. I was particularly interested, Mr. Shane, in your tracing some of the reaction around early tobacco discussions. First, the advertising promotion and the cover-up, well proven now, of knowing of the adverse health impacts, that not being shared. And then as government got involved, that the tobacco industry did not target the government as the bad guy. There was tug of wars and informed discussions. Do you, in your research, what do you attribute this evolution, if you will, to government being vilified, the nanny government mentality? Any sense of causes or projections for how we might grapple with that, other than the examples you shared?
Certainly. So to make a long story very short, we were looking at the era around the 1964 Surgeon General's report, which led to the Federal Cigarette Labeling and Advertising Act in 1965. Basically, the first really bold federal legislation that led to the package warning labels on cigarettes. And what we found was that the tobacco industry was incredibly active, but they weren't attacking the notion that government should do something. They, of course, tried to sully the science on whether cigarettes were causing lung cancer, blaming it on a source of other things. But they only tried to move federal action from the FTC to Congress, where they felt they had more influence. And of course, that's what happened. We ended up getting federal legislation instead of potential action through the FTC. But work done by others has continued to trace this, and there's a very interesting paper out by Stan Glantz from University of California, San Francisco, and some of his colleagues, I forget all the colleagues' names, excuse me, that really look at the active role of the tobacco industry in seeding what's now become the Tea Party, and not just them, but many of the anti-government sentiment, and the real multi-decade work through financing, developing messages behind the scenes. And so the tobacco industry has been one of the players that's really helped make our current discursive environment, in which it's so easy to attack taxes and the role of government, et cetera, to make that possible. So I think that paper is well worth reading. And our own research, which actually extended what I was referring to here, showed that argument didn't, in fact, occur until the middle 1970s. And so again, it was sort of anticipating the sort of movement in which Ronald Reagan comes to power, and that sort of anti-government sentiment becomes such a part of our national political conversation. So I think it's very important to understand that some of the health policy and political battles have actually been a central part of the role of government as it's understood in this country.
Well, thank you. And you did cite examples both of kind of the immediacy of media coverage today and keying on something that might be seen as intruding on individual rights and our history of rugged individualism, and the lack of memory of improvements that have saved lives and are relied upon and taken for granted. So I think maybe one of the questions for us as policymakers, and one of the purposes of today's hearing, is how do we do a better job of making the community at large aware of that? And as you suggested, a healthy democracy is one where the community is involved in crafting, feels ownership of some of these policy initiatives to protect and advance community health, that it's not a top-down imposition, but it's a grassroots effort for protecting the public health. But out of respect for our next panel, I want to thank you all for sharing your time today, and more importantly for the work you're doing in our communities to protect and advance the public health. Thank you very much. And with that, we'll invite our final panel, and I'll remind you, this panel will be followed by public comment. So for those of you who have waited patiently, you will have your opportunity shortly as our next panel comes forward. This is going to be a look at opportunities for additional public health policy interventions. We'll be looking at sugar-sweetened beverage tax proposal, built environments, and alcohol harms and minimum pricing policies. And to lead off our panel, I want to welcome Dr. Harold Goldstein. He's the Executive Director of the California Center for Public Health Advocacy. He'll be followed momentarily by Maurice Ash, attorney and Masters in Public Health, founder, CEO of Change Lab Solutions, and then Thomas Greenfield, PhD, Center Director, Scientific Director, Alcohol Research Group. Welcome to our panel. Thank you all for your patience this morning, and we will lead off with Dr. Goldstein. Welcome.
Thank you, Senators. Pleasure to be here to talk about sugar-sweetened beverage tax, a issue of genuine interest to lots of us. A little background on the California Center for Public Health Advocacy. We're now 14 years old. We're a statewide organization that promotes the establishment of public health policies at both the state and local levels. We spend most of our time addressing the childhood obesity and diabetes epidemics. We led the statewide effort to get soda and junk food out of schools, an issue that in its day was seen as radical and is now considered the standard of care for our kids in schools. We worked with Governor Schwarzenegger to get first time ever funding and ongoing funding for elementary school physical education. We worked with Senator Padilla and a lot of partners to become the first state in the nation to require menu labeling in chain restaurants. And we're now working a lot on soda and other sugary drinks and water as a healthy alternative. So you've already heard from Ron Chapman and others about the obesity epidemic in California. In my adult lifetime, obesity rates have gone up from 9% in 1985 to 25% in 2012. There is no question that obesity is a major epidemic, not just in California, but across the country. I remember 10, 12 years ago hearing a physician talk about what would happen if the obesity rates are not changed, if the curve isn't bent. And they were describing how diabetes rates were going to start skyrocketing, and now we're already starting to see this. In 1999-2000, there were 9% of adolescents either with diabetes or pre-diabetes. Just 8 years later, that's up to 23%. What that means is that what has been predicted, that a third of boys, a third of all kids born in the year 2000, and half of African American and Latino children born in the year 2000 will have diabetes sometime in their lives. What's been predicted that would happen is already starting to be seen. What happens in this state around healthcare costs if diabetes rates go up from 6 or 8% to 33 or 50%? It will bankrupt our healthcare system for real. It has been said that this could be the first generation of children in modern history to have shorter lives than their parents. Again, if we don't do what's needed, we already see where the curve is going. The economic impact of this is also dramatic. Estimated that $52 billion in healthcare costs and lost productivity directly a result of the overweight, obesity, and physical activity epidemics. And we've heard a lot about this already, but let me just go quickly. What's happening? What's changed over the last 30 or 40 years? It's pretty straightforward. We know how the environment has changed. There is now junk food everywhere. Portion sizes have increased dramatically. The food and beverage industry spends $10 billion a year advertising unhealthy foods and beverages to our kids. It is as difficult finding healthy food in a lot of communities as it is driving from here to LA. Have you ever tried to get something healthy along Highway 5 or Highway 99? A lot of cities and neighborhoods are just like that. The Institute of Medicine has said it is unreasonable to expect that people will change their behavior easily when so many forces in the social, cultural, and physical environment conspire against such change. And so in our culture, there's so often this debate, is it about the individual and our individual behavior, or is it about the environment? I'd like to suggest it's the wrong question. We know what's going on. Individual behavior takes place within our environment, within that social and economic and political context. That's where we make our choices. And the extent to which it's about the environment, that's where public policy comes in. That's the job of policymakers. That's why we elect our elected officials, is so they'll address these issues. And we know from public health movements over the last century, whether it was sanitation or drunk driving or violence prevention, most recently tobacco control, the same lessons have been learned over and over and over again, is that the solution is not only a matter of personal responsibility. Of course, education is critical, And at the same time, school and community environments must be changed. Federal, state, and local policies are crucial for addressing those kinds of problems that have general social impact. And that brings us to the whole world of sugary drinks. When we talk about soda and other sugary drinks, we mean these carbonated sweetened beverages, but also sports drinks, iced teas, energy drinks, vitamin waters, fruit drinks. Turns out that all of these sugary drinks are the single leading source of sugar in the U.S. diet. One 20-ounce soda has 16 teaspoons of sugar. Imagine putting 16 teaspoons of sugar in your mouth at one time. Adult consumption is enormous. On average, Americans consume 45 gallons of soda a year. That's 39 pounds of sugar. That's how much my son weighed when he was 5 years old. So on average, we consume a 5-year-old's worth of sugar a year just from what we drink. And for those of us who don't drink any, it means there's someone who's drinking 5-year-old twins. Kids drink a lot of sugar too. 41% of kids aged 2 through 11 drink a soda or more a day. 62% of kids aged 12 through 17. At the end of August, or at the end of October, we're going to be releasing some new numbers on soda consumption by county, so we'll be getting that to you as well. We're talking about an average of 175 calories per day. The adult obesity epidemic is a result of about, we'll see, 278 calories a day is the entire obesity epidemic, right? 175 is what kids are drinking every day for a product that is providing no nutritional value whatsoever. There is overwhelming scientific evidence of the harm of sugary drinks. One soda a day increases the risk of a child being overweight by 55%, increases the risk for women to have diabetes by 80%. 2 sodas a day over 2 weeks increases cholesterol and triglyceride levels by 20%. 2 sodas a day for 6 months increases cholesterol levels, visceral fat, body fat, belly fat, and leads to fatty liver disease in men and women. These are clinical, double-blind clinical studies, the gold standard of scientific research. What happens is we absorb the sugar in liquid form very quickly. In a half hour, we absorb all that. Our bodies are not designed to consume liquid sugar in that way. Also true that these sugary drinks are the most marketed food products to our children. $400 million a year spent marketing sugary drinks to children and adolescents. That's more than $1 million a day in television, digital ads, product placements, and more. Everywhere we go, we see these kinds of ads. And while the beverage industry will be fond of saying that they don't target, they're not targeting kids specifically, we know who it is that our kids look up to. Here's Beyonce. It's really quite remarkable that Pepsi, in the midst of this epidemic, would have the gall to have an ad campaign that says, "Live for now." We could have a subtitle that says, yeah, live for now and die of diabetes tomorrow. And it's not unlike Coca-Cola, whose campaign is now about open happiness. Yeah, open happiness, and tomorrow open your vial of insulin because you'll be needing shots pretty soon. As I said before, soda is a leading contributor to the obesity epidemic. On average, we Americans are consuming 278 more calories per day than we did a few decades ago. Of that, 120 calories come just from sugary drinks. That's 43%. 1977 to 2001, that was during the peak of the increase in the obesity epidemic, which means that these sugary drinks are the single largest contributor to what's been going on here. The economic costs of all this consumption, again, if sugary drinks are one of, if not the leading contributors, it makes a lot of sense to dedicate some public policy time to address it. As I described earlier in my presentation, in no way is it the only contributor, but it is one of, if not the largest contributors. And so, of course, we should be focusing some attention on the biggest culprits. And so we pose the question, what is the economic cost to the state of California as a result of sugary drink consumption? Of the numbers I showed earlier about the cost of obesity and overweight and inactivity, of those numbers, $11.7 billion is just the obesity. Of that, 64% is obesity that's happened since 1984. We don't want to attribute to soda obesity that happened since the epidemic began. So let's discount it by some and address only obesity since 1984. And then we know that even though 43% of the calories come from sugary drinks, if even half of those calories would have been compensated by consuming other things, let's say at a minimum 20% of obesity is attributable to sugary drinks. And that's exactly what the researchers and scientists are saying. This will give us a very conservative estimate of the economic impact. This is the number, this is the externalities number that we're talking about earlier in the day, that says that $1.5 billion in healthcare costs and lost productivity is a direct result of sugary drinks. And the question is, who's paying for all that? What do we do as a state to address those externalities? And Senator Monning, in your leadership, you've put forward a bill to address exactly this. SB 622 would establish a penny per ounce tax on sugary drinks. And that penny per ounce is virtually the same amount of money that addresses, that gets to those externalities. And all of those funds would be used to help turn around the obesity epidemic. More fruits and vegetables in schools, PE, community programs, local control. Communities can decide for themselves how to spend some of this money to pay to fix the unique and proven harm caused by these products. Support for the soda tax is really overwhelming. This is a field poll from just last year. 68% of California voters support a soda tax. 79% of Latinos, 70% of African Americans. If the funds are dedicated to healthy schools, physical education, other obesity prevention efforts. What these kinds of public opinion polls show is that Californians get exactly what it is that we're talking about today. They want their elected officials to address these major problems in ways that solve them for them and their families. Heard earlier about Prop 99. 1988, Prop 99 was passed, $90 million dedicated to social norm change. In just 11 years, there was a 27% decrease in smoking, a 19% decrease in lung cancer deaths. In just 11 years, a 19% decrease in lung cancer deaths, 10% lower than the rest of the country. Deanna Bonta was the head of the state health department at the time. She said, seeing dramatic results like these is proof that what we've done in California has worked. Prop 99 is considered a worldwide model for how to address major public health problems. What we did for tobacco, we can do for obesity and diabetes as well. The head of the World Health Organization recently said that not one single country around the world has managed to turn around its obesity epidemic in all its age groups. This is not a failure of individual willpower. Rather, it's a failure of political will to take on big business. We know who it is that's opposed to these kinds of endeavors. We also know who it is that supports it. It's Californians as a whole. And we know what the effect would be if we don't act. We know what the effect will be if we do. I'm fond of bringing the Constitution with me everywhere I go. Sometimes I bring the old Schoolhouse Rock song that goes along. If you know it, you can sing along if you'd like. This is the preamble to the Constitution. It says, "We the people, in order to form a more perfect union, to establish justice, ensure domestic tranquility, to provide for the common defense, promote the general welfare, and secure the blessings of liberty to ourselves and our posterity, we do ordain and establish this Constitution for the United States." I was sitting around one day and listening to the Schoolhouse Rock version of this with my son, and I realized that this central part of the preamble, that says that one of the fundamental reasons that we established our democracy was to promote the general welfare is exactly what public health is all about, and is exactly what we're talking about today. People want their democracy to be used to promote the common welfare. I want to thank those of you here who see this and have dedicated your lives to enacting this. I want to thank you for that. Thank you.
Thank you for an excellent presentation. I think we will hold questions. We'll get through our panel and then come back with some questions. We're now going to focus on built environments. Ms. Maurice Ash, welcome.
Maris Ash, hi,
Maris,
and
I'm
welcome.
sorry.
I'm glad to be here. And Senator DeSaulnier, we met many years ago, back when you were a saloon keeper. Because I started my career. I had lunch there with Mark Finucane. I started my career in public health in the Contra Costa Health Department a long time ago, so I thank you for your leadership for many, many years, and you've been very influential in my life, and I appreciate it. I'm the Chief Executive Officer of Change Lab Solutions. We're a nonprofit based here in California. We rebranded about a year or so ago. We've been known as Public Health Law and Policy, and we're a blend of lawyers, policy wonks of all stripes, including a big group of land use planners on our staff. And we really serve the nation with model laws and policies. Our first work was in tobacco control in California 18 years ago. We've been supporting the state health department ever since. All the model laws that come out on tobacco control have come from our shop. And about 10 years ago, the state health department asked us to do for the obesity epidemic what we've been able to help the state with on tobacco control. And that led to our first work on built environment many, many years ago, and linking the causes of obesity to the built environment. And it's from that work that I address you today. But I want to go back, and the Constitution is one of the first places you see the commitment to the general welfare, but you can go back to the Mayflower Compact, to when Europeans first came to establish colonies, and you will see language very similar for the purpose of the general welfare. We are coming together and we bind ourselves to form a government in this new land. And the whole purpose of government is what we call the police power. It's the concept in the law. It's the health, safety, and welfare of the population. The health, safety, and welfare. You'll see this repeatedly throughout case law, confirming the role of government in protecting public health. And there was no question, back at the turn of the last century, nobody questioned whether government could have quarantine laws and keep people who had disease offshore until they were proven healthy. Now that we have chronic disease more than infectious disease being the major causes of death and disability, and Dr. Chapman told us about that history just a little while ago, it's the same role of government. It hasn't changed at all to protect the health, safety, and welfare. It's the mechanisms of how government acts that we do that. So really, before we even had colonies, there was an understanding of the role of government, and it was enshrined in the Constitution, and I would say even in our Bill of Rights, and the 10th Amendment in the Bill of Rights really points to the role of the people. Even outside the federal government, the states can act without the federal government acting. And so I really applaud your leadership here, because we in California can take leadership for the nation. And it's that leadership that I want to address around the built environment. I see us at a moment of generational significance, in large part because of the leadership California has taken, and because of the risks ahead if we don't commit to that leadership in the future. This state has made enormous investment in the Affordable Care Act. We are unquestionably ahead of the curve. We are investing incredible amount of money. Our philanthropies have joined with state government side by side to ensure that we get all Californians enrolled. This is exactly the right thing to do. But if we do not invest in prevention, hand in hand with investing in coverage and access to care, as Harold said, we will bankrupt our state. And so now is the time, as we are getting particularly young people signed up for health insurance that haven't had coverage before, to protect those young people from future disease so that we start bending the cost curve. If we don't, if we keep what we've heard today, the disease rates in this state, and don't invest in prevention now, we will bankrupt this state because of our leadership on the Affordable Care Act and doing the right thing. We have to do the hand in glove of the prevention actions with that. Other opportunities of generational moment. This state has made enormous strides in addressing climate change. We have to build on that. We are looking at CEQA reform right now. It's hard, it's politically messy, we have to do it, and I want to particularly talk about infill development in the built environment, particularly in low-income communities. We have a trade-off that often ends up being at the detriment to the very communities that have the highest disease rates and the least opportunity for health. And in low-income communities, Harold talked about trying to find healthy food. That's a built environment question. That's an economic development question. Trying to find a safe place to play or a bike lane or a hiking path. It's impossible to find those sorts of amenities in areas of concentrated poverty. We will find high disease rates, low educational attainment rates, low economic achievement rates. And all of those can be blended together with a built environment perspective that both creates healthy infill, brings wealth into low-income communities, desperately needed to break up concentrated long-term poverty, and protects existing communities from dislocation and disruption. So that's the challenge facing the state of California. It has to be addressed. If we just simply push low-income communities out to the suburbs that are not served by transportation, not served by social services, not served by job opportunities, we will not be solving any problems for the state. It might, solve a problem for downtown Oakland where I work, but it's not going to solve a problem for the suburbs surrounding our central cities that will be absorbing the low-income communities without any sort of infrastructure for that to happen. So the challenge that I want to place to you and the role of government in solving this is really looking at infill guidelines, CEQA protection. OPR is developing guidelines for health in general plans. This is well within the expertise and the role of state government agencies to set the standards for how development will be achieved throughout the state to make sure that there's access to safe places to play, to make sure that low-income communities are protected in their housing while at the same time bringing in higher income residents and opportunities. We have to have both. It's not an either-or game these days. That we're using our transportation dollars. The federal government's basically abdicated transportation, transit systems. Let's just do more highways. The state, all the actions at the state and local level now, the leadership on transportation to make sure that we have bike lanes. The discussion, I'm just so impressed with the knowledge of this body of already what's happening well in Europe and other places, Latin America, on built environment and cycling and transit. This is the opportunity we have now in California, and the state is really being given the role and directing the local governments accordingly. The other challenge that I want to put out is redevelopment. We have not had redevelopment for a few years. I understand that the government doesn't want to hear the word redevelopment for a few years. Now is the time to be doing the thinking about what's going to come in the place of redevelopment in the future. Last redevelopment law was in the Health and Safety Code. Did we in public health embrace it and know what it was about? No, not at all. And just when we started learning about how redevelopment can be channeled for public health, poof, it was gone. It was evaporated before our very eyes. I would like to encourage that the next round of whatever we do in this state stays in the Health and Safety Code, that we integrate health and safety criteria, ethos, values deeply within redevelopment, because this is going to be the key to working in low-income communities with the highest disease rates. We need to have housing with accountability. We had housing goals in the last redevelopment, but there was insufficient accountability. We need transparency in the use of the funds. We need a health in all policies ethos in the use of the funds. Just putting up and other freeway off-ramp with a big box store selling all the junk food and the low-wage jobs won't cut it for the future. It will not cut it with the Affordable Care Act and having everybody covered by health insurance. We have to do better. We have the opportunities to do better. We have the future of redevelopment in front of us, that now's the time to be doing hearings just on that issue, and I encourage you to think of health and safety. I want to pick up and change the subject just briefly, if I might, and get to the marketing issues that have come up repeatedly this morning. You will see on our website a lot of information about marketing, tobacco and junk food and soda marketing to kids. It's one of our specialty areas. Started in the tobacco control days. We used to we got rid of we had 40 cities in California that had gotten rid of tobacco billboards before 2001. And in 2001, Laura Lard v. Riley, the U.S. Supreme Court invalidated all of the work we had done in the states. Riley was the Attorney General in Massachusetts. A case came out of Massachusetts. We were not sued ever in California, I might say. Our U.S. Supreme Court's jurisprudence on regulating marketing does not go in the favor of public health. Let me just be frank about that. But that doesn't mean there isn't anything we can do. And one of the things that we can do, and I think it's an abomination that we have any advertising of junk food and sodas in our schools. That is not protected by the First Amendment. It is not commercial speech. Schools are an area where government can regulate speech, and I think must regulate speech to protect our children. So I hold that out to you as an opportunity to your legislature to grapple with. I would also like to just go on record in saying that advertising is not presented to communities in equal measure. The amount of advertising in low-income communities far exceeds the advertising in higher-income communities. Back in the day when we got rid of tobacco billboards, what the state health department funded boys and girls clubs in low-income communities, and they did the best barefoot epidemiology I ever saw. And I'm sure you got this when you're on the Board of Supervisors in Contra Costa, because Contra Costa was a lead. They went around and we didn't have GIS, as we do today. They just used maps, and they put dots on where all the junk food, the tobacco billboards were. Then they put little notations. What game was being played? What was happening? What was the race of the people? What was the language at the billboard? So just really social epidemiology. So they did that in their own neighborhoods, and they went to the higher income neighborhoods and mapped those billboards. Oh, there weren't any billboards in the higher income neighborhoods. Oh. Then they went back to their Boys and Girls Club and looked at the epidemiology of who's dying from tobacco-related diseases, and the only conclusion they could draw is they're trying to kill us. And they presented, the third stage of their work was presenting, learning to speak truth to power. They presented their findings to city councils and board of supervisors, 40 different communities around the state. And in every instance, local government took action to protect those kids. Now, we can't do that work anymore, thank you to the Supreme Court, but we can still protect kids. And some things that we can do is just look at billboard laws in general and the proliferation. This is a local government issue, not so much of a state government issue. We can't pick and choose what kinds of messages are on billboards, but we can look at the proliferation of billboards, particularly in low-income communities, and the per capita impact of those billboards and for people who are forced to live in certain neighborhoods. We can also look at the front of the stores and advertising. We have the Lee law in California that limits advertising to 30% of storefronts. That's mostly from law enforcement, so the law enforcement can see into a store in case there's a crime going on and know what's going on. We could lower that. We don't need to have 30% of fronts of stores have advertising. There's so much that we could do to affect particularly people most directly impacted. I would start with schools. I would also think, and I'll just mention this, and I wish I knew we were going to have this because I could have come better prepared, but our consumer deception law in California, it's a state law. We could look at that. I would talk with the Attorney General's office that's charged with protecting that consumer protection law and enforcing it. What's the reasonable person standard? How do we define deceptive and unfair advertising? And who gets to enforce that? We took away enforcement of any person could enforce it. We took that away, I think it was Prop 64 a few years ago. We could look at that again and see and opening up the enforcement. If the AG's office isn't going to work and nothing this is not targeted at our current AG in any form or fashion, but many AGs are running for governor, and they won't take on big business and big industry, particularly the pharmaceutical industry, the soda, or the tobacco industry. It's just not going to happen. And so if we want to see a strengthened consumer protection law, we might need to open up both definitions and who can enforce the law, so we get a little bit more play in protecting the population. So I will stop there. I'm glad to talk more about any of these issues. I want to just emphasize housing in low-income communities is a built environment issue. It's well within the state to protect people and bring new wealth into concentrated poverty. Thank you.
Thank you, Ms. Ash. Compelling testimony. Thank you for your dedication to work in this area. Our final presenter on this panel will be Dr. Thomas Greenfield. He's the Center Director and Scientific Director of the Alcohol Research Group. Thank you, Dr. Greenfield, for joining us today.
For inviting me to this panel, and appreciate the chance to, let me just get this going here. Yeah. So this is a very specific talk, rather than really the Maurice's wonderful opportunity to look at a number of specific laws, but this will look at one specific area. So to give an overall picture, this is a graph that shows the rates of alcohol consumption per capita, and you can see that it has fallen since the 1980s, but it then has risen in the last decade, although there's been a little bit of fall off with the economic recession. We do see in our data that people exceeding the guidelines set up by NIAAA and the dietary guidelines has actually been increasing at least through 2010. And I want to make the point that we look a lot at drinking patterns. And so it's much more important to us to see harmful patterns than just simply the volume, because the volume can be attained by light drinking, or it can be obtained by extreme drinking. So we look more at that issue. So we've talked about externalities here, and I want to bring your attention to one area with alcohol, which is that we've taken good account of alcoholism and the problems to the individual in large numbers when people become dependent. But what's less understood is there are large externalities from heavy drinking, and it's beginning to be studied in much greater strength now, and I want to bring a little bit of that information to you. Alcohol is so affordable that today it's roughly 15 times more affordable than it was in the 60s, and that's because of a combination of increased wealth and decreased real taxes. And taxes are very hard to impose on alcohol, partly because a lot of people enjoy lighter drinking, and taxes don't fare well, as you'll see a little bit later. But when we look at the externalities, these are some of the things we see. Particularly women are very affected by financial harms, very affected by family and marital harms. That's largely because men tend to drink more, and in effect, there's an externality for women and families, both through loss of income and also through spousal abuse and even child endangerment. The areas we see that I think are quite interesting in terms of the largest level is actually passengers with drunk drivers. And this is more men than women, actually. Surprisingly, I would have thought that more passengers were in couples were women, but actually men go out to drink in groups as well and put themselves at risk in this way. And then being assaulted, men are much more assaulted by strangers, certainly, than women. And some of that is exposure in the areas that they are, in fact, drinking, in areas where there are congregations of unruly males, usually, but of course, sometimes unruly females as well. You have very large numbers who are affected by what you might consider victimization the innocent, the secondhand drinking effect. And this is something that we are quite interested in. I mentioned that alcohol taxes are not easy to find support for strengthening. Most people want taxes to remain about the same. So what I'm going to actually move to is basically pointing out that we do find that people who have been harmed by drinking, and that amounts to 55% of the public, adult public, are actually more supportive of alcohol control measures. So a slight majority who have been harmed at some time are actually more supportive of alcohol policies, and that's really all alcohol policies. I want to then come to a case study of a policy that I want to recommend as a possibility that is different from taxation in the usual sense, and that is to establish minimum pricing. And this is something that the alcohol industry is actually much less opposed to than simply broad tax measures. And one of the reasons is that the big producers realize that it's sort of the bottom feeders that set the standard for the lowest cost. It's not in the drinking establishments where, you know, for the most part, there is fairly high cost of drinking. It's people who buy rot gut, cheap alcohol and take it home. And so a minimum price will have the effect of reducing consumption that is disproportionate to the amount of actually involved. So I want to say that in Canada, this is pretty much assumed. Most of the provinces actually have minimum pricing. And the alcohol producers have signed on to the strategy in the Canadian alcohol strategy and have not actually opposed this, and it's the norm. So this is another situation where just a different culture has generated a norm that is very supportive of this notion. Coming to the specifics, you know, we need evidence, first of all, of some impact on consumption, particularly heavy consumption. We need some evidence that that in fact reduces harm, and then we need to know something about costs. And so here are some of the evidence, first of all, on consumption. So there's an overall reduction when you have a 10% increase in minimum price of about 16%. And if you look at an average minimum price for all drinks, it's still in the right direction. It's still significant. It's not quite as strong. And you can see beer, much less effect, wine, more effect. So coming to hospital admissions, it's a fairly strong effect. And you can see that there's acute harms, which would be injuries and so forth, from heavy drinking occasions. And there's also chronic harms, which come from excessive volume, however it's consumed, by heavy drinking. As you know, it causes cancer and 60 other conditions. So this is definitely something that fits the data and fits our expectations. And again, minimum price is a quite strongly supported evidence-based policy. And then lastly, I would say, when you come to actual attributed deaths, that too is where you see a dramatic effect. And you can see there in some of the chronic conditions, with a delay, there's quite a substantial effect of raising minimum prices. So it's something that I think is worth considering, and I'll finish up by saying that I think, you know, we feel that paying attention to externalities is a key for the sort of alcohol policy of the future. I think looking for policies that are excellently supported and won't immediately have strong opposition at this time is a good strategy. And I think minimum price is something we should look at very actively in this sense. Thanks very much. I do have handouts, so I'll pass them out after that.
Okay, thank you. The sergeant can help if you want to hand them to the sergeant while we talk. We are going to open it up to some of our questions first. I'd just like to get a show of hands. How many people are prepared, would like to make comment when we open to public testimony? If you could just raise your hands. Good, I see a few, but not an overwhelming number, so we will get to you shortly. We are going to have just a little further dialogue with this panel. If I might just start with Dr. Greenfield on the minimum pricing practiced in Canada.
Right.
Is tax built into that? Is there does some amount of that go to public health efforts?
I think it's probably a good idea to do that. In Canada, I don't think specifically they do, but they do invest heavily in public health in general. So
Right.
I think it makes sense to consider that. Although typically our experience with Prop 34 in California, of course, was that actually earmarking actually caused some problems for the passage of that, I think.
Thank you.
There's been, if I could jump in, a lot of work. I don't know too much about alcohol, but I know a lot about tobacco, and there's a great body of research that we've been looking at minimum price laws in tobacco for a long time and how to do it well. There are minimum price laws in most states that don't mean anything today, or in many states, because they were passed over 100 years ago to get at predatory, when lowering the price to undercut the market, and they wanted to protect against that. Only New York State does it right, because what happens if you have a minimum price, if you don't control for coupons and other sorts of advertising, the coupons will come in, the 2-for-1 offers in tobacco,
And you lose
and
that.
you lose the benefit of the minimum price. So when you start regulating these promotional activities, you have to be careful because of the First Amendment and commercial speech. So there's a complex body of law that we'd be glad we've written on. We're working with researchers in tobacco control all over the country and are developing model legislation literally as we speak that could be implemented at the state level, and we'd be glad to share that
Great.
with your body.
Thank you. And if I could ask a question of Dr. Goldstein on the sugar-sweetened beverage. You did comment a fair amount on the impacts of advertising, targeted advertising. I think all of you had threads of impacts of targeting certain communities for advertising. So we're aware in California of two examples, Richmond and El Monte, where efforts to impose a sugar-sweetened beverage tax were defeated rather overwhelmingly, and yet the data from the field poll that shows a large majority of Californians favor such a tax if the revenue is directed to health promotion and physical education, et cetera. How do you reconcile those rather dramatically different measurements of public support?
No, I think your question really points to exactly what happened. According to Prop 13, at the local level, in order to establish a tax and dedicate those funds to any specific purpose, to have the money go into a special fund, it's called, it requires a 2/3 vote of the electorate. In both Richmond and El Monte, they, I think quite reasonably, didn't think they could get a 2/3 vote, and instead they went for a majority vote. A majority vote bill then requires the money go into the general fund. As a result of that, people weren't convinced that the money was going to be used for those things that even though proponents were promising would be used, because there's nothing in the law to guarantee that it would be used. So instead they did a Part A, Part B on the ballot. We'll establish the tax, majority vote bill, money goes into the general fund, and Part B says, well, we the people encourage the city council to use the money in a certain way. People weren't convinced by that. So I think regardless of what it is that the beverage industry and others, the story they're telling about what really happened in Richmond and El Monte, I think that's really what happened. And what that means is that soda taxes at the local level are at least initially more likely going to get passed only when you can get a majority vote, a 2/3 vote. But
And
it
what
also
was the
means-
role of advertising in those campaigns? What was the proportion of spending in
spending
support
was-
of the measure versus opposition?
The spending was about 60-1. The beverage industry spent $3.5 million compared to proponents spent less than $100,000. And, we got lots of pictures we can show you all over Richmond. The billboard said not one penny of this money is guaranteed to be used for kids' health. Again, that's a result of Prop 13. And it
So
does
that's
mean
another thing you could work on is Prop 13.
Yeah.
Thank you.
Thanks. Well, we've also seen a focus in the beverage industry advertising. They've chosen not to challenge the health data, and they've shifted it to this individual choice issue. And the TV ads that they're pouring untold millions into suggests that efforts to tax sugar-sweetened beverages constitutes removing choice, which in fact no proposal that I'm aware of seeks to take the product off the shelves. It seeks to price it commensurate to more healthful drinks. So I guess my question, that was more of a comment, are there any models, other states or other countries who have succeeded in trying to get ahead of the curve on these impacts leading to obesity, preventable diabetes? I mentioned Mexico.
Yep.
Maybe you have some more information
No,
on
I think
that.
we're just at the very beginning of this worldwide movement to get at the role that sugary drinks have played in the obesity and diabetes epidemics. The Surgeon General's report on tobacco came out in 1964. It was a long time before taxes started being passed. This new research on the direct link between all of this sugar we're consuming in liquid form and both obesity and diabetes is relatively new. We're talking in the last 3, 4, 5 years. So we're going to see over time, all over the world, dramatic increases in the number of places where this is happening. Mexico, as you mentioned, the president of Mexico has put forward a peso per liter tax. That's about half of what SB 622 would do. It's still a very meaningful amount. And in Mexico, which has the largest consumption of soda in the world, I've heard recently diabetes is now the leading cause of death in Mexico. That's a big deal for the president of Mexico to say we have to solve this problem. Next up is actually going to be, so they're going to be first up. They're going to be making decisions in October. On the other extreme, in some ways, the city of Telluride, Colorado, has a tax on their ballot in November. And I think we'll see, we're certainly talking to a lot of different places around the state and around the country who are very seriously thinking about this. There have been more than a dozen states that have proposed soda taxes. My guess is in the next 5 years, there will be a couple of states at least, hopefully California being one, that have passed these taxes, and numerous cities all over the country that have done that. And I think the beverage industry knows, I think they're prepared for this. I think they want to just wait this out as long as possible. But in time, sugary drinks will be taxed. It'll be as common as tobacco taxes are. And we'll all be used to it, just like we are with car seats.
Thank you. Senator DeSaulnier, any questions or comments?
I want to thank you all. This has been very inspiring. One thing that comes to mind, though, as we listen to these examples is even our best examples are reactive after the fact. And I know this comes from the American legal tradition, as I have a colleague who's an attorney here. And we talk about the precautionary principle in Europe and the Roman law versus what we adopted in British law. So we make, under CEQA, a lot of talk in this building about how CEQA doesn't work, but we make people who have a project in land use that's detrimental to the environment mitigate those impacts, whether it's levels of service. It just has always frustrated me that we don't apply the same sort of measurement to consumer products to defend public health, because we do it incrementally, or we do it after. If we're lucky, we do it after the damage, and we're responsive. So hopefully we've got lots of good ideas. I always used to say if we ever get to the point in the state where public health was as valued as public safety, we would have enough political capital to make the changes that quote from the director, Dr. Goldstein, you had up there might be easier for us, because I know in the chair's instance with his bill, that's a extremely, as you know, whether it's Richmond or here, a huge lift to get it through. And then the other part is just what we talked about earlier, is making the public realize that this isn't choice. Rent-taking is taking away your choices in many ways. And the issues about redlining in poor communities where I remember our community development director in Contra Costa, because we didn't have records for all the use permits on the billboards, he had to wander around the county with his staff trying to find them. So this is such a great hearing, and I would just ask all of you to try to work with us to develop a legislative package for next year. I know Senator Bell, who isn't with us today but has a committee hearing starting right now in San Francisco around mental health, has a very serious interest in these issues as well. So thank you for being here. Thanks for your passion.
Thank you, Senator DeSaulnier, and for your leadership in this area. And I think one of the comments you just made about public safety versus public health, I think we've also learned today that they are ultimately very, very much connected. And I think that's part of our challenge and opportunity to show the link between public health and public safety. So again, thank you to all of our panelists. And at this point, we'll invite those from the public who would like to share maybe a couple of minutes of testimony. We are going to need to start to wrap up, but we don't want to cut you short. But if you could be brief, and hopefully interest shared can also be included in our ongoing conversation here. So if you want to lead off, and please introduce yourself.
Sarah DeGia on behalf of the California Pan-Ethnic Health Network. Thank you, Chair Monning and Senator DeSaulnier for being here, and for the staff for also preparing a really great overview. And thank you both for your commitment and leadership on these issues. I think particularly looking at how to integrate health into other policies is a really important factor as we move forward. We all know that the goal and the role of health, public health, is to benefit the overall population. However, research and data shows that communities of color are far more impacted by certain health conditions. And so I would just like to, emphasize that as we move forward, that we really look at the effect and that we don't ignore the impact of racial and ethnic health disparities. Research and data shows that people of color are actually currently the majority of Californians. And those under 18, 72% are from communities of color. So 3/4 of our upcoming population are from communities of color. The median income, however, of whites is 50% higher than African Americans, Latinos, and American Indians. And students of color in California feel a lot less safe than students that are white in their schools. African Americans have the lowest life expectancy rate of all of our ethnic groups. So as we move forward, I think it's just really important that we make a concerted effort to really look at the ways to address but also racial and ethnic health disparities within a public health framework. That social and environmental determinants of health do impact health, but it's also discrimination and the intentional planning of communities that have left out certain of these communities. And Dr. Rudolph also mentioned the idea of when we look at policies, most of our health policies don't just go to the health committee, but they've actually been in transportation, in local government, and in education. And so to have a health and equity lens through these, I think, are really important. And Senator Monning, your bill, AB 441, which looks at health and equity in transportation and highlights those policies in the regional transportation plan guidelines, is, I think, just one way that we can continue to move that forward. So again, thank you for this opportunity, and again, just really encourage and look forward to working with you on how to integrate the racial and ethnic health disparities.
Thank you so much for your work and leadership in these areas. I know one of the slides today showed the kind of zip code disparities, but if you go under the zip code, as was articulated, there's the markers will be economic and racial, and we need to be mindful of that data in how we build towards more equitable distribution of resources and health promotion. So thank you for your work in that area.
Senator
Mr. Kim.
Monning, Senator DeSaulnier, Doug Kim, on behalf of the Primary Care Association, we want to thank you very much for this hearing. As you know, our community clinics and health centers are in medically underserved areas. In addition to providing preventive care services, we also partner with the public health community. We have a public health task force within our organization. We were pleased to support your SB 622. And we're also, Senator DeSaulnier, pleased to support your SB, was it 809 on the drug abuse. We look forward to continuing our partnership with you, following your leadership in the area of public health. And we want to thank you for making sure that we have the resources to provide the services, both the preventive services and the behavioral health services to our clientele. And we thank you for helping provide the resources for us to do that. Thank you.
Thank you. Yes, sir.
My name is Steve Barrow, and I'm the president of a group called Advocates for Health, Healthcare, and Economic Development. We're also focused on underserved communities, but I'm also one of the founding members and still on the board of the California Coalition for Children's Safety and Health. That was the organization we created after the state created in 1990 and 1991 a strategic plan for unintentional injury prevention. We used that group to pass the drowning car seat helmet laws. I was one of the lead people on helping to do that back in the 90s. And there was a lesson learned that I wanted to share with you on the economics of that, because one of the things, my organization and the organizations I've always worked for, Children's Advocacy Institute, et cetera, we're always focused on the disparities in our communities, and especially those communities of people of color. And one of the things that I did when I was leading the bicycle helmet law effort I was the only person, but I was charged in the building to do that, is I met with all the helmet manufacturing companies. And this was in 1992 when we started putting the bill together. We passed the bill in 1993. It went into effect in 1994. And one of the things I asked the executives of all of our helmet companies is, what is the average price of a helmet? Before we got into passing the law. It was $50 or higher in the state of California, and that was in the nation. I asked them that if we required 10 million children, and if only 30% of them actually got a helmet on their head, what would be the price of a helmet at a Target store or a grocery store? And they said it would be $10. So one of the things that we always look at in public health, we're always looking for, okay, there is the public policy, there's the cost savings in healthcare. You've heard a lot about that. Excellent testimony today. Thank you for doing that. But one of the other things I'll tell you is we also have to look at what is the cost to the consumer. When we pass these laws, consumers actually, we want them to carry it out. If they have to buy a car seat, if they have to help build a playground, if they have to buy a helmet, can we use the law rather than doing pilot programs in small areas, go statewide and then build back? And we did that with bicycle helmets, and you go and buy a bicycle helmet for $10. That's just one of the economic lessons.
Well, it's a good economic lesson that shows us how we might engage industry at a more buy-in level.
And one final thing is, it was a strategic plan that the state put forward that allowed everybody to come together to move forward on those laws, the helmet law, the pool law, and those. We're leading, along with the California Coalition for Children's Safety and Health, in cooperation with the Department of Public Health, Safe and Active's community branch, Safe Kids, Drowning Prevention Foundation. We're having a conference in December 9 and 10 here in Sacramento to kick off the development of a brand new comprehensive unintentional injury strategic plan for the state of California. We'll be reaching out to your offices to inform you about who's all going to be there and how we're going to go about it after the conference. So.
Thank you so much. Thank you for your work. And Mr. Ackerman, welcome.
Thank you, Senators. Bob Ackerman on behalf of the California Nevada Soft Drink Association. I think this might be a tough room for my comments, considering we have the author and co-author of the SSB tax bill on the dais. You know how we feel about this. Obviously, we're very much opposed to singling out soft drinks in this equation. Obesity is a problem, but it's not the solution to tax one product. Sugar-sweetened beverages account for 7% of caloric intake of the average adult. Obviously, calories are an issue. Lack of exercise is an issue. Lifestyle, et cetera, genetics, all those things go into making up the problem at hand. So we agree the solution more is education. Industry has been at the forefront of labeling our products more clearly. When you pick up a package of any soft drink now, on the front of container labeling, calories are posted right there. When you look at the vending machine, calories will be there shortly. When you go to the fountain, you'll see the calories in the beverage you choose. It is about choice, and it is about having those options available. Industry is leading the way in terms of offering low and no calorie options, and the sale of regular sugar and sweetened beverages is declining. It has been declining for some time. We expect that to continue, and we're obviously not opposed to that. We are about having a healthy community, and we want to be a part of that. So the solution is the issue. This is not a small tax. It's a huge tax. I think the last estimate from the Board of Equalization was $1.7 billion out of California consumers' products or pockets to pay this tax. And when you look at the marketplace in terms of how beverages are priced, we don't think it will have the desired impact about sending price signals to consumer. When you go down the beverage aisle, when you look at a vending machine price for beverages, when you go get your fountain product, the price is all the same. No guarantee that's going to stay that way, but you don't see a difference in pricing among products, be it diet or regular. We don't think this is going to have the desired impact, but simply probably raise prices for all, which is not a good thing for California consumers.
Well, thank
Appreciate
you, and we appreciate your being here and your continued engagement. I do think you remark there have been, we've seen trends of diversification of products and more healthful products on the market. But I think where we have a fundamental philosophical difference is, as you framed it, the question of consumer choice versus government intervention or regulation. Having heard some of the testimony here today, I'm just curious how you reconcile your opposition to any focus on sugar-sweetened beverages in light of some of the evidence of effective public health interventions with other products.
Be happy to give you some of the competing science, as it were, as well. I think the issue of causation is important. Sugar is available, obviously, in a wide variety of food and beverage products, and it's not the only source via those who consume regular sugar-sweetened beverages. So sugar and calories come from a variety of sources. We think, again, it's the broader picture rather than just looking at that. So I guess we'd argue causation in terms of these products have been around for a long time. Diets have changed. Physical activity has changed. All those things. Genetics have changed. Those things need to be examined as well before we start casting the net on one product.
And I appreciate that. Some of what we have seen is some of what's also changed is the size of containers going from 8 or 10 or 12 ounces to 20 ounces being the standard delivery vehicle in vending machines. The markets and retail outlets with bigger and bigger containers at lower and lower cost, and the concentration of the fructose in those beverages that are being consumed in greater numbers, and the advertising continues to encourage people to drink those products. So to me, there's still a little bit of a disconnect of the representation of concern for public health and some of the diversification in product, and yet what appears to me to be uncontrovertible evidence of the concentration of sugar and the proven incidence of increase in obesity and, well, just sheer caloric intake and not healthful calories. And so people ask us, they say, well, today it's sugar-sweetened beverages, tomorrow it'll be hamburgers and French fries, and you want to tax fat. The distinction is there are other foods that are maybe not the most healthful choices, but they have some beneficial calories in them. They have protein, they have some vegetables. Most of these sugar-sweetened beverages have no nutritional value, and we know they are having a particular impact on the pancreas that catalyzes the bad health effects. So how do you respond to that?
Well, I think portion size certainly is a problem in the obesity epidemic, no question about it, in all types of foods and beverages. So we've gone the other way on that. We now have smaller size containers available. I guess our response to that is we make them available in all shapes and sizes, in all types of caloric content. We make that content very clear and aware, and we would expect people to make informed choices and good choices about, moderating caloric consumption and balancing that with physical exercise. So at the end of the day, there's nothing more personal than diet. A lot of tough decisions to make in terms of how we do that every day. We all deal with that on a daily basis. And so we think that awareness and choice in container size and caloric type is the key to this, and people taking, sure, it is personal responsibility because it is our own bodies we're dealing with.
Right, but within a social environment that we've discussed, and I don't think we're going to change each other's minds this afternoon.
Probably not today,
But I look
no.
forward to our ongoing principled engagement here. And I guess one issue you raised, the very important factor of physical education, physical exercise. We have a more dormant society in terms of more lethargic, more time in front of computers and televisions. I'm wondering if the industry you represent would be amenable to, if not a tax per fluid ounce, helping with some further investment in physical education programs in our public school systems.
I can't speak to, whether we would accept any kind of a tax or fee. I will tell you that I think this industry is very much engaged and always has been engaged in the communities in terms of sponsoring a variety of activities, some athletic-driven, some scholarship-driven. I mean, they are engaged, and I think they've always been a part of their local communities. So we welcome that opportunity. I think we continue to look at other opportunities to encourage awareness and exercise. Working with the First Lady, Let's Move campaign. I think those things are all very positive, and we see that the things are changing in terms of the numbers coming out recently. So I think we're open to that, and we work at the local level, and would be happy to continue those conversations with you.
Great.
I have to say, since I didn't get forgot to put it on my list of comments, the Dr. Goldstein, who I dearly love and have happy to engage with him on a frequent basis, references to the public opinion polls regarding sugar-sweetened beverage tax. I think the public has spoken very loudly in those two recent local elections. Yes, you can argue about the merits of how the money was directed, but they spoke very loudly in terms of rejecting additional new taxes as a way to.
Don't you think, though, a 60-to-1 advertising advantage doesn't exactly result in a level playing field in registering voter opinion?
Well, I think that in this case, this is unlike many ballot initiatives where you have to figure out who's on what side and what the initiative really does. I think those initiatives at the local level were very straightforward in terms of what people were being asked to accept or vote on. So we could argue about, whether or not they were influenced by the advertising campaign. Hopefully they were. That's our right to do so, obviously. But I think it also very clearly reflects public's attitudes towards additional taxes and money taken out of consumers' pockets.
Well, again, I appreciate your being here today. I do look forward to our ongoing engagement as hopefully SB 622 moves forward in the process. And I do look forward to our offline continued conversations as well. And I do appreciate the contributions of the industry you represent to community programs, scholarships, et cetera, that on its own should be recognized for the merit of those contributions. So we thank you.
Thank you, Senator.
Thank you. Any closing remarks, Senator Saulnier? Any other public comment? Seeing none, I just want to thank all of you for being here, particularly the panelists who've given of their time, but to all of you. And just my closing comment, we've heard varying references today to the implementation of the Affordable Care Act, and I think we've heard some comment of its effort to invest more in prevention, in building healthy communities. But I think we also walk away with a conclusion that there is no health care reform that will be successful in reducing costs and building public health if we don't have a health care system that converts from the treatment of chronic illness and disease to one of health promotion and wellness. And that is not just a function of government, that is a function of informed communities, of our related medical communities, of our educational communities, of community organizations. I think we've somewhat lost the ability to advance a vision of what a healthy community should look like. We've been with tough budgets, a very reactive legislature. We need to take back the ability to articulate a vision of a healthy community and healthy communities in this state. And I look forward to being part of that conversation, as I know Senator DeSaulnier does. And I think we also, just as we look at the nexus between public health and public safety, we also have to look at the scourge of growing trends of poverty in the state of California and our nation. There was a very high-profile war on poverty that started in the 60s, and now we're almost averse to even using the word poverty in describing the health of our communities. And I would say there's a very direct correlation between growing trends of poverty in our communities and growing trends of chronic disease. And so we need to look at the multifactorial issues, social, economic, political, that are affecting communities that are not getting rid of poverty, they're going deeper into poverty. So with Senator DeSaulnier, we are establishing a Senate committee, a select committee on ending poverty in California, and we'll look forward to engaging many of the public health advocates who have been here today in helping inform that committee's work as we look at trends of poverty in the state of California and how it affects all Californians, not those just living and trying to survive in a state of poverty. So with that, I want to thank all of you. I want to thank our sergeants and our technicians. For any of you who may have tuned in on the internet, if you're still with us, we applaud you and look forward to our ongoing work. And a final thanks to our wonderful chief consultant on Subcommittee 3, Michelle Bass, for her amazing organization of materials and witnesses. Thank you. We stand adjourned.